All right, let's get started. This is Ifan Peng from Weill Cornell Medicine. I'm glad to host today's tutorial, CVPR 2021 tutorial on when image analysis meets nature language processing, a case study in radiology. So in recent years, the emerging techniques of deep learning have been widely and successfully applied to many different computer vision and text mining tasks. But when adopted in certain domains like radiology, these techniques should be combined with extensive domain knowledge to improve efficiency and accuracy. Therefore, there's a critical need to take advantages of medical image analysis, clinical text mining, natural language processing, and deep learning to better understand the radiological words and permits to enhance the clinical communication and patient-centered care. So this tutorial at CVPR 2021 aims to bridge the gap between the medical imaging and medical informatics research to facilitate the collaborations between the communities and introduce new paradigms of machine learning, exploiting the latest innovations across the different domains. So in today's tutorial, we are honored to have 6 speakers, Alistair Johnson, Subi Al-Araf, Matthew Logan, Aman Banerjee, Yingying Zhu, and me to present the recent work on radiology medical image analysis. So here is the schedule for today. Each speaker will give 25 minutes or 30 minutes talk. Those talks were pre-coordinated before. And during this tutorial, we will just play the pre-recording one by one. And if you can also access this pre-recordings from the websites. They are all online on YouTube. So if you have difficulties to access the Zoom link, you can also watch the pre-recordings on YouTube. Today's tutorial will be a break into 2 parts. In the first part, we will have 3 speakers, and in the second half, we will have 2 speakers. If the speakers are available, there will be 5 minutes QA at the end of each session. Otherwise, we will have a 30 minutes panel discussion to answer all questions raised by the attendees and others at the end of the tutorial. So it's scheduled at 3:30 East Standard Time. So during that time, we will have a QA panel discussion. All speakers will attend during that period. Okay, so that's the schedule for today's tutorial. Any questions or comments? All right, if not, I will introduce our first speaker. Okay, our first speaker is Dr. Alistair Johnson. Dr. Johnson is a scientist at the Hospital for Sick Children in Toronto, Canada. He has extensive experience and expertise in working with clinical data, having published the MIMIC-3, MIMIC-4, ICD, CRD datasets, and also recently mimic ED datasets. Most recently, he also published a new dataset called Mimic CXR, which is a large public available dataset for chest X-ray. So in today's talk, Dr. Johnson will introduce his work to build high-performance chest X-ray classification models and understands why they are all wrong.
Hello everyone, I'm here to tell you about deep learning in chest x-rays, give you a nice introduction to working with this type of data, and hopefully give you some tips and tricks to understand the context in which you're working. So I won't bury the lead. There's only 3 things I hope that you take away from this tutorial. The first one is that it's really important to learn about the domain you are working in, to understand the context in which the data are collected and which they are used. Along the same lines, it's very important to understand the data generating process. What I mean by this is, why are these images collected? Why is this information collected? In what context is it collected? And understanding what impacts that context could have on your models that you build. And finally, I think it's very, very important to understand what data you don't have. So what information could be used by a domain expert to make a prognostication, for example, which you are not incorporating in your model, and what could be the consequences of that. So chest radiographs, a very interesting modality. Basically, you're taking an image of the chest or the thorax, right? And you're getting a nice image of the heart, and you're getting a nice image of the lungs. And of course, you can see some other anatomy in there. And the main idea is to look for anything that's sort of abnormal that you might not expect, and try to incorporate that into the current clinical context of the patient, and see if you can figure out maybe a pathology. So what do we really look for in these chest x-rays? Well, we're looking for, as I said, an abnormality in the heart, or a pathology in the heart. So here's an example of an x-ray where the heart is very, very large. And this tends to indicate that the heart is working very hard, which means that there may be some sort of illness along those lines, something like congestive heart failure, right? Alternatively, of course, you're also looking at the lungs. You're looking for what you want to see in a good pair of lungs, right? Nice, full of air. So if you see some kind of water in there pooling at the bottom, especially, then that's clearly something that you want to understand why that's happening, and maybe figure out if you can help the individual to overcome this illness. But it's not necessarily just water, right? It could be any type of fluid, and you know, we're talking about the body, so it's not water that we're talking about. We're talking about sort of a general fluid, but in some contexts you can actually interpret that it may not be the sort of generic plasma. It may be blood sort of leaking into the lungs, or some sort of pus, and then you're interpreting it differently. So you're sort of using a lot of physical laws and physical principles to interpret this image, and try and understand what's going on with the patient from the image. So it's very interesting. Basically, radiologists have this very strong mental model of what should be in a sort of chest x-ray, and in a medical image in general, and they're able to use this sort of prior knowledge to understand pathology. And so I won't say that all these parts of the anatomy are actually visible on every chest x-ray, but you know they're there, so you're able to understand that if something is unusual about a certain area, it may be because something is unusual about that part of the anatomy. So why should we do machine learning in this context? It's always important to ask sort of why should we bring machine learning AI into this field? What are the sort of ethical implications of doing that? And when it comes to radiology, there's actually quite a limit on the number of human resources. So if you look at resource-constrained countries or regions, there are very few radiologists for the general population. And it's just widely known that any delays in medical imaging are all across the board bad, right? You want to understand what's going on with the patient as early as possible, to help them as early as possible. And it's not just limited to resource-constrained areas. Even in very resource-rich areas like the United States, rural areas tend to not have that many radiologists, and it's an important consideration for those areas as well. So what do we need to do machine learning? Pretty straightforward, right? We need some data, we need some models, and of course we need a lot of free time to tinker with those data and tinker with those models. So let's go ahead on this journey and let's try and build some machine learning classifiers for chest X-rays. So happily, a few years ago, the NIH came to the rescue. There actually used to be only 4,000, 5,000 chest X-ray images publicly available for machine learning, and then the NIH came along and they released a data set of over 100,000 images. Lots of excitement here because now you're talking about a large enough size that you can use some of these very fancy automated feature extractors that we call deep neural networks. And a very exciting time because these images also came with 14 labels, which meant you could do supervised learning, which we were getting and we continue to get very, very good at when it comes to imaging. Great. Okay. Definitely NIH were not the only ones who started to share data. My group personally, we shared a data set, and there are others as well. I tried to come up with a list of all the different data sets, but I can't really keep up, which is great because there's a lot of data sharing in this area, and radiology really seems to be an area which is embracing this sort of AI craze. So, there's actually a lot of data out there, slightly different formats, very important to consider the different resolutions and image data types. For example, some of these data sets actually come as DICOMs, right? And a DICOM is a very, very high resolution image, which also comes with metadata. It's a very standard format in medical imaging, but there are some interesting aspects of that high resolution. For example, DICOMs are actually 16-bit, which is higher bit depth than you can see with your human eye. So when they're visualizing a DICOM, they actually truncate the resolution. It's in a process called windowing, so you can actually visualize what's going on with your eyes. So there's actually higher resolution in native DICOMs than there are in PNGs and JPEGs and those sort of compressed or uncompressed image formats for that reason. So very important to actually consider the data type that you're using, but there's a lot to sort of work with, which is very exciting. So, okay. And actually, one particular thing I found interesting is within 1 or 2 days, three groups independently published chest X-ray data sets. So we went from basically the NIH chest X-ray data set being the sort of dominant source of data to all of a sudden there are 4 different databases with over 800,000 chest X-rays. So it was really great, and there's a lot of research that has been done because these data were made available. So great, we have some data. Now we need some models. I won't get into the details of computer vision. There's a lot in this conference which does a better job at explaining recent advances than I could ever do. But we're going to really use a dense net here. This was just something, when people were trying out a few different models, dense nets seem to work fairly well. So most chest X-ray models are sort of based on a dense net architecture. But I don't think it's particularly important to consider only this architecture, and I'm sure the lessons hold for other architectures as well. Okay, so we have data and we have models, and this is basically what led to a paper called ChexNet a few years ago, where they took the NIH data set of chest X-rays, they classified them into pneumonia or not pneumonia, and they used a dense net. And this was a very sort of exciting paper because it actually purported to do as well as radiologists in classifying these chest X-rays. Now, there are a lot of caveats when you say you're as good as a domain expert, and I highly recommend reading the blog post that I linked to at the bottom there, which sort of talks about how you should actually evaluate humans when comparing to your algorithm. And the sort of the short version of it is that the radiologists were evaluated in an environment that wasn't true to their daily practice. So they are using smaller sort of compressed images, well, with only 1,000 by 1,000 resolution, right? This is what the data set came out with, which is very different than their normal environment, where they are able to zoom and window, like I mentioned earlier, and also see previous images for the patient and read about their clinical context. So it's a very different environment. I think it's fair to say that that's not a true test of a radiologist's performance. But clearly the model did well, right, if it was even asking those questions. So very sort of interesting work there. However, when you looked at some of the saliency maps, so if we look at where is the algorithm driving a lot of the predictions for pneumonia, in some cases, it was very good. So if you look at the image with the thumbs up, right? This was identifying opacities in the lung, which are associated with pneumonia. And there were sort of multifocal opacities, in multiple places. So it was great. It was identifying regions that a radiologist would identify to come up with the diagnosis of pneumonia, right? But if you looked at some of the other images, it was looking a little bit all over the place, which was weird. And in particular, it was looking at regions outside of the lungs, which does not make sense for pneumonia, because pneumonia is a condition that you find in the lungs. So you shouldn't really be using information outside of the lungs in order to make that diagnosis. And if you are, something weird is going on. And again, it's very important to understand the data generating process. So if you actually look at x-rays and medical imaging in general, it's very interesting. It's very, very protocolized, right? So when you're thinking about natural images, right, and all the data sets we have of natural images, it's people taking pictures in all sorts of different environments. Objects are rotated, objects are far away, close to you, and there's also sorts of considerations in managing that. But with an X-ray and with medical imaging in general, there is a technician who is trying as much as possible to measure the patient in the exact same way every time, right? So there's two different mechanisms of taking a frontal x-ray. There's AP and PA, anterior posterior and posterior anterior, right? So front to back and back to front. And these two imaging approaches, these two ways of having the patient stand during imaging, have big impacts on the way the image looks. So if you look at the front to back anterior posterior view, right, you can actually see that the heart is bigger, right? And if you think about the physics of the situation, that's because you are shining, x-rays, or let's just pretend it's a light, you're shining a light, and the heart is casting a bigger shadow on the actual imaging plane, right? So this means that a heart could look bigger if you take it in AP than PA, which means that if you're diagnosing, say, cardiomegaly or a big heart, you actually need to factor in the orientation of the patient, right? So that's one big factor, right, that we need to consider. Not all these X-rays aren't all measured in the same way, and this could have an impact on our model's performance. And you can see a lot of different subtle aspects of the image which drive these differences. But also, by the nature of the measurement, many sort of systems actually write down the orientation of the patient and whether it was a portable X-ray which took it, or a non-portable X-ray. And AP images tend to be portable because you're usually always going for a PA, but if the patient is really sick, then you'll do an AP. And so you can see this image at the top right. It says AP erect portable. It's telling you, oh, this is how I took this image, so make sure you factor in this context. And of course, a model can pick up on this. It can read these words and it can say, oh, if this is AP erect, then this patient couldn't come to the radiology department. That means this patient is sick. That means maybe they have pneumonia. And the models actually do pick up on this type of information. There's a very good paper which sort of explicitly models this, where they try to classify the hospital from which an X-ray came. Not any finding, not any diagnosis. They just tried to say, which hospital did this X-ray come from? And they're able to get almost perfect performance because the tag that is used to indicate which side of the patient is the left side was different between the two hospitals. And there are all sorts of these process features which can leak into your model and drive up performance when classifying a radiologic finding, but not actually be using causal features. And so we see this in a very recent paper where they're actually explicitly evaluating the saliency maps against radiologist segmentations. And in some instances, it's very good in that the saliency maps are very consistent with what a radiologist would annotate. But in some instances, it's fairly poor, and it's reasonable to assume that the model is using some sort of process factor in order to classify the radiologic finding, which is not what we want, right? We want it to use the causal features so that we know that the model will generalize, or at least we know that it's more likely to generalize. That's our sort of running hypothesis. Okay, so what do we do about this? Well, we can block out the non-causal factors, and we saw a lot of this sort of research when trying to analyze sort of conditions of the lungs, where let's just isolate only the lung, and then let's build our model with only the lung, and then we know for sure that our model has to use the sort of lung features. Segmentation is a hard problem, so this is harder than it sounds, but it makes sense and it's reasonable. What's our other solution? Well, we could actually explicitly model these non-causal factors. So we can sort of almost add a regularization term, which says, okay, I know that these two X-rays were measured at different hospitals, and that's what domain is in this figure. So I am just going to explicitly try to model that those two different hospitals, and then I want to subtract that sort of learning from my underlying representation. Two different ways of tackling the sort of similar issue of these non-causal factors. Finally, there's a very interesting, more sort of stats-oriented approach, which is just stratify your patient population appropriately. So if you look at this sort of middle figure, you can actually see that the source of the X-ray and the view projection actually clusters these X-rays very nicely. So which machine you use has a big impact on the representation that is learned from the sort of neural network. And so if you actually stratify your population and remove this information from the sort of data, then in some instances the model actually is unable to learn anymore. So in this instance, they were looking at hip fractures. When they remove the information about the scanner model, when they remove the information about what orientation you were taking the X-ray, they actually found that the model had chance performance at classifying fractures, which is a little bit scary, right? So you can't just do a cross-sectional study of these X-rays. You really have to think about this data generating process. Okay, second issue is that we're very often using noisy labels. So here's an example of an actual radiology report, and I've bolded a section there where it says underlying interstitial lung disease slightly limits evaluation for pneumonia, but no new large opacities are detected. Now, if you put on your radiologist brain, okay, this is basically saying, you know, it's a little bit hard to see, but I don't see any big white spots in the lung, so I don't think they have pneumonia, right? However, our NLP algorithm has actually said that this is positive for pneumonia because it hasn't quite been able to interpret the sentence to negate the mention of pneumonia, right? And this is what I mean when I say this is a challenging problem. You know, understanding natural language is sort of AI hard, NP hard, whatever you want to call it. And so, right, this is not going to be easy to solve. But of course, there are solutions, right? So here is a before I get to the solutions, here's sort of highlighting this issue. This issue happened with the NIH data set. They were pretty explicit about their NLP performance in the sort of publishing paper, but a manual inspection of the data found that there were these sort of inconsistencies between the image and the label. And in fact, research is still trying to figure out ways of managing the fact that your NLP algorithm won't always be 100% accurate, and you just have to deal with that noisy label because it's impractical to have a domain expert label thousands of chest X-rays. Okay, so solution number one, right? Just improve the natural language processing. Just solve natural language processing. It's not that difficult, right? We can just, you know, at this CVPR, we can yell at all the NLP people to do a better job, right? So, you know, you'll actually hear about some improvements to the NLP algorithms in later sessions from Ivan. And so, you know, I won't talk too much about this, but this is definitely something that you can improve upon. The second one is sort of to learn with noisy labels, right? Just explicitly acknowledge that your labels will be noisy, and let's model that noise, and let's not treat the label as perfect, but let's treat it as sort of a probabilistic label, which may or may not be correct. And so there's some interesting work in sort of adopting these learning with noisy label approaches to radiology reports and learning with chest x-rays. Okay, so our third and sort of final issue is that we're not incorporating the clinical context. So when I showed this to a colleague, they asked me, why is the chest x-ray and the radiology report in a Hoover? So this analogy clearly doesn't work for everybody, but basically we can't look at these two data modalities in a vacuum. That was what it was meant to be, a vacuum. Um, let's look at an example, right? Okay, let's pretend we're radiologists again, and we have a chest x-ray, and it's for a 78-year-old woman. And so we're going to write the findings section. So we are going to write what we see in this chest x-ray that's sort of relevant to the patient's health, and which just sort of describes it. Okay, you can try and write it yourself. I've written one myself. Okay, so I can see that the patient has 12 ribs, okay, and they have 2 clavicles. They have both their lungs, which is great, and their heart is between their lungs, right? Um, I don't see any fractures in the clavicles. I can kind of see one arm, but not the other. Okay, so you get my point, right? Is that there's a lot in the chest X-ray which we could describe, which we don't, right? Because it's not relevant to the patient's care. And when you're looking at a chest x-ray or a medical image, it's very important to acknowledge that the radiology report is not someone annotating an image for fun, right? It is someone who is looking at an image and answering a clinical question. So there is an indication section where the person who ordered the image says, look, this is the individual, right? And they have this going on and they have this going on. And I'm wondering if they have this sort of pathology. Can you help me? And the radiologist says, okay, yes, I see that. There's definitely this pathology going on. I see this other one. Here's what I think this could be, right? So the radiology report is not a ground truth label. It's a conversation. And it's very important to factor in this indication when you are understanding an image with its impression. So a lot of methods will sort of just label the image with the impression. But if I didn't ask you about, say, fractures in the image, then you're not going to mention it in the radiology report, even if there is one, or at least you're not necessarily going to. So if we look at the sort of workflow of a pneumonia admission, there's a lot of information which drives this clinical context, right? So if a patient comes in from the community, there'll be triage, there'll be a note, they'll have their vital signs taken, there'll be a history, there'll be some diagnosis that is done, some diagnostics, excuse me. So blood work, the chest x-ray comes in here, but also with a physical. And all this sort of information is combined together in order to understand what's going on with the patient. And we'll hear more about sort of combining multimodal clinical information with the chest x-ray later. And doing something like this is very important, for example, with a diagnosis like pneumonia, because pneumonia is actually a clinical diagnosis. You cannot make a diagnosis of pneumonia from a chest x-ray alone. You need certainly the information from the chest x-ray is useful, but you also need systemic sort of signs that the patient has some sort of illness. It cannot be done from the chest x-ray alone. So in some instances, you absolutely have to use all this information. Otherwise, you just don't have the full picture. So with that, I hope you learned a little bit about the data generating process. I've included a Colab notebook where you can run through with some saliency maps and see some sort of flaws there and get a sense of how these models work and maybe try them out yourself. And of course, check out the other sessions which go into more detail about multimodal clinical data modeling or improving NLP models. And I'd also like to just thank all the institutes and the people who made all this data available. We couldn't do any of this research if these people didn't take the leap and just put all this information out into the sort of public domain for public benefit. So thank you to them, especially. We wouldn't be here without them. And thank you for your attention.
All right, thank you, Dr. Johnson, to provide this pre-recording. Again, you can watch the pre-recording on YouTube, and if you have any questions, feel free to tap in the chat box. We will monitor the chat box, and we will ask your questions by the end of this tutorial in the QA session. I think that's the most efficient way to communicate with the speakers. So we will have a short break, and I will play the recording of our next speaker at 12:40 Eastern Standard Time. All right, let's continue. Our next speaker is Dr. Subi Al-Araf. Subi is assistant professor in the Division of Cardiology in the Department of Internal Medicine at the University of Arkansas for Medical Sciences College of Medicine. His main research interests include the investigation of the diagnostic and prognostic utility of non-invasive cardiovascular imaging modalities. So today he will give a presentation on deep learning for cardiovascular imaging applications. Here it is.
My name is Subi Al-Araf, and I am an interventional cardiologist at the University of Arkansas for Medical Sciences. As part of my research work, I have published on several applications of machine learning within cardiovascular disease. And for this session, I will present on the topic of deep learning for cardiovascular imaging applications. For disclosures, I'm currently funded by the National Heart, Lung, and Blood Institute, and I receive royalties from Elsevier for a book that I was the lead editor on, titled Machine Learning in Cardiovascular Medicine. I have been in clinical practice for the past 10 to 12 years, since graduating from medical school. During training, we are taught and mentored to practice medicine in a specific sequence. The usual workflow entails obtaining a comprehensive history with documentation of symptoms and prior medical events. The next step is to examine the patient, followed by performance of blood work and usually obtaining an electrocardiogram. Based on the above, a differential diagnosis is established, and based on most likely disease condition, a diagnostic imaging test is ordered, which can include an echocardiogram, a stress test, an MRI, or an invasive coronary angiogram. At this stage, a diagnosis is established and a specific treatment plan is determined. However, there are several intrinsic limitations of the aforementioned workflow that I will highlight over the coming few slides. Firstly, symptoms are not often reliable, as many patients deny or minimize symptoms, and some have atypical presentations. The figure is a radar plot showing the frequency of atypical and typical chest pain presentation in men who are in blue and women who are illustrated in red. On the right is the presentation in patients who end up having a heart attack, and it shows that a proportion of patients, predominantly women, present with atypical symptoms. On the left is the presentation in patients who end up not having a heart attack, and it shows that a more significant proportion of patients present with atypical symptoms and is equally distributed between men and women. The physical exam is an important part of clinical assessment and is heavily relied on in order to establish a specific diagnosis. However, the physical exam is not very accurate. In a survey of 30 pediatricians who blindly examined 37 children with murmurs, sensitivity was 82%, meaning that 18% of children with significant murmurs were missed, while specificity was only 72%, meaning that 28% were thought to have a significant murmur, while in reality the murmur was benign. After further testing was performed, likely an echocardiogram, specificity improved to 98%, but sensitivity remained in the 80% range. In addition, a physical exam is not consistently performed. In a survey of primary care physicians, cardiologists, and cardiac surgeons from 7 European countries, only 54% of patients with known severe mitral regurgitation were examined and listened to during clinical assessment. Thirdly, acquiring imaging studies can be labor-intensive and time-consuming. In order to acquire a scan, it requires extensive technical and interpretation expertise, which by itself requires many years of practice and experience. Scans are also labor-intensive, and other than scanning, they often require manual annotation of structures and determination of measurements. In addition, there is significant intra and inter-observer variability when imaging studies are interpreted. Furthermore, imaging studies have become a central aspect of clinical care. When someone presents with a cardiovascular ailment, a diagnostic imaging test is almost always ordered by the evaluating physician, and findings on imaging scan can guide downstream management. We live in an age where numerous imaging modalities exist and are available for clinical use, which is something that did not exist in the distant past. It includes echocardiography, which is an ultrasound of the heart that provides dynamic images and information about the structure and function of the heart and valves. There is cardiac computed tomography, which provides non-invasive details on the anatomy of the coronary arteries and the distribution of plaque, as well as the heart chambers. Cardiac magnetic resonance imaging provides high spatial and temporal resolution images and is useful for tissue characterization as well as functional assessment of cardiac structures. And finally, invasive coronary angiography, which has been around for many years and is considered the gold standard for not only diagnostic purposes, but it also provides an avenue for percutaneous interventions. Finally, risk assessment is crucial in management of patients. Yet, risk scores are far from perfect. Current scores include a limited number of well-established risk factors. Statistical modeling that is often used assumes a linear relationship between risk factors and a specific outcome. Further, they use restrictive modeling assumptions. And finally, there is minimal integration of imaging data, which are mostly used for diagnostic purposes, but not often used enough in an integrated fashion for prognostication. The bar figure on the right is an analysis from the REGARD study, and it shows a consistent pattern seen in similar analyses where risk scores under or overestimate risk at the higher and lower end of the spectrum compared to the actual observed risk. And despite all we do, cardiovascular disease remains a significant cause of morbidity and mortality worldwide. This is data from the WHO, and it shows that cardiovascular diseases are the leading cause of years lost in China, India, and North America. It is followed by neuropsychiatric disorders and respiratory disorders, which might be on the rise in the era of COVID-19. The expansion of machine learning provides an opportunity to improve clinical care by capturing the strength of both machine learning as well as standard statistical approaches. Machine learning provides data-driven modeling, employs an agnostic approach for data analysis, which can provide knowledge on new associations that were previously uncovered through statistical modeling. Standard statistics, on the other hand, provides modeling that is based on previous observations and assumptions and draws inferences from associations between specific variables and a chosen outcome. When leveraging both approaches, there is potential for creating more accurate and precise predictions that is robust to future applications and allows for the integration of actual data as well as images in an integrated and comprehensive approach. Using AI within healthcare promises to improve cardiovascular care by providing quality care wherein correct information and interpretation is provided for patient care, through value by maximizing the amount of data and knowledge extracted from imaging and clinical studies. And finally, by improving access, wherein people all over the world start having access to quality care. Artificial intelligence is a branch of computer science concerned with building smart machines that are capable of performing tasks that are typically require human intelligence. Machine learning is a subfield of AI that focuses on creating predictive algorithms through the unbiased identification of patterns within large datasets and without being explicitly programmed for a particular task. Deep learning, on the other hand, uses multiple layers to progressively extract higher-level features from an input, which is most often an image. In such a manner, these networks transform many problems into a form that can be solved by computers. Deep and more intricate models mean greater capacity, but on the other hand, require significantly larger datasets. This is a simplified representation of the architecture of a CNN. These networks typically have three layers: an input layer, hidden layers, and output layer. This figure shows an example of how a CT image is processed so specific features are learned in consecutive layers of the model in order to segment out a specific cardiac structure. And in this case, it is the cavity of the left ventricle that is shown. And specifically with the integration of deep learning within healthcare, it can help with better image acquisition. And we are seeing research, especially with echocardiograms, CT, and MRI. It can improve the workflow associated with image interpretation and reporting, and it can automate clinical decisions. The latter will obviously take time, as it will take humans a while to trust machines and algorithms making decisions on their health and disease conditions. However, it is important to keep in mind that for deep learning models to work, an investment in time, expertise, resources is initially required. Establishing the ground truth when it comes to structures on an image is paramount for model training. However, it requires expertise and can be time-consuming depending on the complexity of the question that is being asked. For the main part of my presentation, and for the sake of time, I will briefly touch upon 4 areas within cardiac imaging where deep learning has been used. The first part will focus on coronary calcium scoring, followed by coronary CT angiography, then myocardial perfusion imaging, and ending up with percutaneous procedures. The presence of coronary artery calcium has been associated with the occurrence of adverse outcomes. With the more calcium there is, the higher the chance of a future heart attack or cardiovascular death. In addition, the absence of any coronary calcification has been consistently shown to predict a very low yearly event rate for adverse cardiac events. As such, the routine assessment of the calcium score has become an important aspect of patient care. Measuring the calcium score takes time, and in a busy clinical workflow, it can take away significant time from actual patient care. Several groups have investigated the use of deep learning for automated segmentation and calculation of the calcium score. In this analysis by Singh and colleagues, a set of 512 by 512 input images were fed into a modified UNet model with an encoder and a decoder unit. The output was a segmentation mask identifying the presence of calcium in any of the major coronary arteries, the aorta, and any background noise. The investigators were able to achieve an overall DICE score of 0.952 for the task of segmenting coronary calcium. This figure shows an example of the original image showing calcium, which is bright white, and the coronary arteries around the heart. The next set of images are the ground truth labels, and the final set of images on the right show the model prediction. And we can notice the perfect overlap between the ground truth and the model prediction. The color corresponds to a specific artery, while pink in this example shows extra cardiac calcium, which is not usually included in the actual calcium score. Coronary computed tomography angiography differs from routine calcium scoring in the fact that contrast is given, which makes blood bright and hence enables the physician to evaluate the inside of a specific structure as well as the wall and surrounding structures. Coronary CTA allows for the assessment of the coronary arteries, but a lot of other structures are often visually assessed for disease or enlargement, as quantitative assessment can be very time-consuming and not practical within the existent framework of practice. Bhaskaran and colleagues used the dataset of annotated CT images from 206 patients in order to develop a deep learning model for segmentation of structures from CT images. On the left is the overall structure of the model used, and on the right is an example of a good prediction mask, as exemplified by a die-score that is close to 1, and an example of a poor prediction with a die-score that is 0.4. Green are the ground truth labels and red are the prediction masks. On top, the ascending aorta is predicted well with excellent overlap between both masks, but on the bottom, the pulmonary artery prediction mask is missing a portion of the artery, as evident by the green area that is missing from the prediction mask. The investigators were able to achieve a die score of 0.82 for 8 different structures. This figure shows model performance for the ascending aorta in A, descending aorta in B, superior vena cava in C, inferior vena cava in D, coronary sinus in E, pulmonary artery in F, right ventricular wall in G, and the left atrial wall in H. Moving on to myocardial perfusion imaging. Myocardial perfusion imaging is a form of stress testing which is done for the purpose of evaluating the blood flow within the coronary arteries and to evaluate changes under resting conditions and during stress. The change in coronary flow can be indicative of the presence of significant or obstructive coronary artery disease. Myocardial perfusion imaging is widely performed, and image interpretation and analysis can be time-consuming and require significant resources. This is an example of the images that are obtained during a myocardial perfusion scan. Panel A shows a single angular projection of the torso, while panel B is a single slice sinogram through the heart showing perfusion of the myocardial muscle. Panel C is a polar map with all myocardial segments represented in a single image, while panel D shows the 3 multiplanar reformatted cardiac views that are typically used to interpret these scans. These images are compared at rest and after stress, and any changes in perfusion are accordingly interpreted. In this analysis from Betancourt and colleagues from Cedars-Sinai in LA, they developed a deep learning model for the prediction of obstructive or significant coronary artery disease in more than 1,600 patients. The training dataset included patients who had both a stress test as well as an invasive coronary angiogram, which served as the ground truth for the presence of significant coronary artery disease. The investigators used 3 feature extraction units as well as 3 fully connected layers for 3 outputs, each corresponding to the probability of obstructive coronary artery disease in one of the 3 major coronary arteries: the left anterior descending artery or LAD, the left circumflex or the right coronary artery, or RCA. Finally, we will touch upon percutaneous procedures, which encompass any intervention that is done in the cardiac catheterization lab and does not involve open heart surgery. So the modality of choice in the cardiac catheterization lab is X-ray fluoroscopy. However, it doesn't provide exact imaging needed since it's two-dimensional imaging. And secondly, the heart border is not clearly visible on fluoroscopy. These images show an example of a transseptal procedure where an operator is required to cross from the right atrium to the left atrium for a specific intervention. When that is required, the location of the septum or the border between the right and the left side is estimated based on operator experience. Often, a second imaging modality, such as echocardiography, is also used to confirm the location. Once the septum is safely crossed, then the desired location is reached and a specific intervention is performed. Existing technology for hybrid imaging involves overlaying echocardiographic images onto fluoroscopic images in order to provide the operator with a better visualization of nearby anatomical structures and in order to maximize the chances of success while minimizing complication risk. Unfortunately, such an approach does not provide a true appreciation of the three-dimensional anatomy and relationship between structures, and in reality does not add much, especially in the eyes of an experienced operator. One of the advantages of CT imaging is that it provides three-dimensional volumetric imaging of the heart and surrounding structures, especially when contrast is used with opacification of cardiovascular structures. So deep learning has been used to co-register fluoroscopic images as well as CT scans that are typically obtained before an intervention is performed. In these cases, the spine has been used as a fiduciary marker since it's easily seen on both CT as well as fluoroscopic images. Thereafter, the model is trained to recognize specific catheters and devices used by the interventionalist, thereby creating a real-time augmented reality system to guide procedures in the catheterization lab. This way, a preoperative CT scan is obtained, three-dimensional segmentation is performed on the structures of interest, and using automated co-registration of CT and X-ray images, the three-dimensional anatomy is provided to the interventionalist in real time through an augmented reality system. Such a tool has the potential of providing actual three-dimensional orientation, which not only can improve the safety of the procedure, but can also minimize time, radiation, and contrast usage. So in summary, images are a source of vital diagnostic and prognostic information. Artificial intelligence promises to improve and further optimize workflow within healthcare. In addition, the application of deep learning could help with image acquisition, analysis, and improve risk assessment. Nevertheless, the application of deep learning has its challenges, including the need to establish an accurate ground truth, which requires expertise, time, and resources. Thank you.
All right, so again, thank you for, thanks Ruby for preparing the recorded video. Again, if you just join this tutorial, we will probably not have a Q&A session for after each speaker after each video, but we will definitely have a QA panel by the end of this tutorial. So if you have any question, feel free to type your question in the chat box and we will monitor them. Okay, then let's take a 5 minutes break and I will introduce our next speaker at 1:10 p.m. Eastern time. Okay, let's get started. Our next speaker is Dr. Matthew Longren. Matthew is a co-director of the Stanford Center for Artificial Intelligence in Medicine and Imaging, and also associate professor, clinician scientist at Stanford University Medical Center. His NIH and NSF-funded research are in the fields of AI and deep learning in medical imaging, precision medicine, and predictive health outcomes. So today, Matthew will give a talk on clinical context for medical imaging deep learning models, model fusion techniques to combine medical imaging with structured clinical data.
Hello, everybody. I'm Matt Lundgren, and I'm the co-director of the Artificial Intelligence and Medicine Imaging Center at Stanford University and associate professor in the Department of Radiology. I'm going to talk today about applied multimodal data fusion for medical imaging at the point of care. So when we think about medical imaging projects, we often think about sort of very pixel-based analysis, right? So here's an example of a 3D imaging exam, so a multi-slice CT of the chest, which was performed to evaluate for pulmonary embolism, which is a dangerous condition that is often very important to identify. And there are many solutions on the current market even for this problem, for automatic identification using the pixel data to identify this condition. And it's an important problem to try to solve. It is something that is increasingly problematic for the healthcare system, at least in the US, as these studies are often very expensive and resource intensive and are frequently ordered in a variety of conditions that present looking like pulmonary embolism, but actually in fact turn out to not be. And so it has become a very much important type of examination to consider around either automatic identification of this disease or potentially reducing the number of studies that are done for this purpose because of its strain on the healthcare system. And in fact, this has been a focus of legislation recently to identify pulmonary embolism, and of course the CT examination example that I showed you is exactly the study that's used to identify pulmonary embolism. There's been a lot of work to try to reduce the resources necessary to make this diagnosis. And so we sort of sought to create a 3D kind of model to look at this problem because, again, it's a multi-slice problem. So just as many groups do, we focused on building a supervised modeling approach that could identify pulmonary embolism with high degrees of accuracy at the expert level. And the existing approaches in the literature, they tended to use extensive, computationally expensive pre-processing and feature engineering, which were kind of over-engineered and really not capable of end-to-end inference in a clinical workflow. And so an important component of this was leveraging a 3D model as opposed to a 2D model. And it was pre-trained in this case on Kinetic 600, which is a very well described, basically the ImageNet for video, in order to create a model that had initializing weights to move forward in sort of analyzing these types of studies in a 3D fashion. And we needed to explore this computationally inexpensive solution that could digest the entire exam series. Our key insights were focused on the squeeze excitation network, which happened to have won the most recent ImageNet challenge. And then, of course, again, as I mentioned, the pre-training on a 3D video series. In case you're wondering, the squeeze and excitation networks basically have these building blocks for CNNs that improve the channel interdependencies at very little to no computational cost, which was important for us. And again, they were able to achieve state-of-the-art on the ImageNet challenge, beating the best result by 25%, which again, it was fairly significant for that challenge. And the network weights of each of its channels, it weights each of the channels equally when creating the output feature maps. And so these blocks are all about changing this by adding a content-aware mechanism to kind of weight each channel adaptively. So it's quite an efficient approach. And this was work led by Mars Wang, who's a PhD student in my lab. And so our result was phenomenal for this work. We were able to come up with both state-of-the-art performance on Stanford PE studies for identification, as well as an external validation data set at another hospital where we did not obtain training data, but then applied to a test set. And we even built, as you can see here, just a simple visualization tool. And all this was done in a very short period of time. As this is not a surprise to most of you in this audience, it is certainly possible to create a given use case and generate a model that can do it in an automated way. We also made this data available for the RSNA challenge after publishing this in one of the Nature journals. And so you can actually go and access highly curated, annotated pulmonary embolism CT data, annotated by expert imagers, subspecialist radiologists, and that was part of the 2020 RSNA Pulmonary Embolism Challenge. And this data is from several countries and 4 institutions and comprises more than 12,000 different CT studies. So it's the largest data set of its kind, and had more than 80 expert thoracic radiologists as annotators. Eventually, we had 784 teams from around the world that participated in this challenge, and the top 10 teams, many of which open source their solutions. So basically, what I'm trying to paint a picture for you here is that we've really have a great mechanism and system as a field right now for creating a clinical use case, potentially making the data available, but at the very least being able to build models with the flexible tools that we have available to us in the community to address pixel-based medical imaging problems. But what I want to talk about today is the concept that medical imaging is more than pixels. And this is actually lost on a lot of what you're seeing in the field right now and in general. When physicians who are trained in imaging, like myself, look at an imaging study, we don't just look at the imaging pixels alone. Now, we do a lot of other things. We actually tend to take in all of the clinical context and the information surrounding the situation that led to this exam being done. And the reason there's a gap is that currently we're seeing most data sets don't include that information. So the companies and many of the groups that are working in the space have focused on almost uniquely just on the pixel data. But as we know in the field, we've known for years since our field began that medical imaging data is incomplete without contextual information to make the best diagnosis. And this plays into issues around robustness. It plays into issues around deciding on what diagnosis is important. And this is not just in imaging in radiology, at least. This is in other specialties that use imaging, like pathology and ophthalmology and dermatology. We need clinical context and data to ultimately make the best decisions. But as I've just shown you, we can easily create state-of-the-art performance in a retrospective fashion for pixel-only tasks. And when you see these benchmarks that compare to human experts, that again is often done in a situation where the human expert also is not given the clinical context. And the challenge there is that you're actually creating an artificial environment that does not reflect real practice. And so what kind of other information do we have? Well, in addition to the pixel data, the things that we rely on, I've listed here, and this is just the types of EHR data that we would use for the pulmonary embolism use case that I just pointed out. And so we actually set out to say, could we create a model based on the contextual information, not the pixel data, that could do the same task as our pixel model? So in other words, can we take all of that EHR data and use it as clinical context for a given patient and predict whether they likely have a pulmonary embolism or not? So we actually created a prediction model, again, based on patient timelines. So over time, what does their EHR data look like? And with some feature engineering, sort of set up a pipeline that allowed us to look at various approaches, including neural network models, elastic net, which is sort of a regularized regression, which sort of combines L1 penalties of lasso and L2 penalties of ridge to overcome some of the limitations in high dimensional data that have a relatively small number of samples, at least in relationship to the number of features. And this is all very common practice in sort of the EHR, both structured data and even some unstructured data work. But the goal, just to make clear, is to take a contextual information, create a model that can predict the likelihood of pulmonary embolism without the pixels, and then help us decide, does this person need to be imaged or not? If they're low, they don't. If they're very high, maybe you start treatment as opposed to waiting for the result of the image exam. So this model has utility in and of itself, independent of the pixel data, and this is work done by Imam Banerjee. And so to look at this, just like we do with our other models, we wanted to see how our performance was against what our traditional rules-based or scoring systems that humans would use. And we found that in the Stanford healthcare system, where the model training data came from, the neural network actually performed the best. And we also did external validation, just like in the other case, in this case with Duke, and found that the model was robust to external validation. So again, this is a clinical context model. This is not pixel, but it's performing a task that typically requires pixel data to make the diagnosis. So there's a lot of excitement here. Why? And by the way, we published this in JAMA. So why is this important? So we can actually integrate this system into the existing workflow where a patient comes into the emergency department. They may undergo a traditional scoring system to rule them out for the disease, but our perform model could actually come into play here in the moderate to high risk and help triage patients as to whether they need imaging or not, based on, again, the contextual data around that patient. And we found that we could reduce this imaging study, the need for the imaging study, the need to get the pixels, we could reduce it by up to 20%. Without increasing the false negatives and causing potential harm. So this is very exciting. So what does this mean? Well, let's just think about this now. We have a vision model, as I told you, that had fairly good performance, that looked at only the pixels. And now we have an EHR model that only looks at the clinical data or the context. So you probably understand where I'm going with this. Here's an opportunity for us as a field to try to match what human experts do and use the pixels and the clinical context together to make the best diagnosis. And so we actually did some literature search and actually ended up doing a full analysis of the literature that we published in Nature that sort of described the best practices around fusing multimodal data in order to solve an important clinical use case. And so how does this work? Well, we tried to be very prescriptive in the sense that we took different approaches and came up with some terminology. And I invite any of you to take a look at this paper and see how it might apply to your work. But in general, as you'll hear from some of the other speakers, we have early fusion, joint fusion, and late fusion. We try to categorize these. And the early fusion is really where you're concatenating the original features or the feature representations at the very early input level. With a single feature vector before feeding into the machine learning model for training. And that's kind of, you can see that there where things are being concatenated early on. Joint fusion is kind of in the middle of the extremes where it joins the features at the input level, but the loss is propagated back to the feature generating model or intermediate fusion, which has this join learn feature representations from intermediate layers of neural network models with features from other modalities as input to a final model. So you can kind of get a sense that there's a couple different approaches of this joint fusion. While at the other end of the spectrum is this late fusion, where you aggregate results at the decision level, very similar to an ensemble, but this sort of leverages predictions from multiple models to make a final decision. And so just having that sort of common language and understanding of how multimodal data fusion could work, you can imagine that you could take clinical context or clinical data and pixel data and go through a variety of these different approaches to training a unifying multimodal model to figure out which one works the best for your use case. And so we tried this with our project where we had the CT imaging data and we had the EMR data, and we tried several different approaches. We've actually ultimately found that the late fusion in this particular case worked the best. But we did actually improve the model. Having that clinical context really did make a big difference for us, and our fusion model reached state of the art. And again, this is an end-to-end solution, which is even more useful for a clinical context. And we looked in and found some examples of where the pixel-only model was wrong, but when it had the clinical context, it was actually more accurate. And again, we published this work most recently in Scientific Reports. You're welcome to, again, check these out. All of these are open access, by the way. So where does this go from here? Well, it turns out that in a lot of our work, we're getting a lot of interest from clinicians who are interested in using these models, not radiologists, but actually frontline clinicians who want to try out these models at the point of care when they're taking care of their patients. Why is this interesting? Well, as it turns out, in our current healthcare system, the way things work is that you go and see your doctor, and that doctor orders imaging tests. And then there's this period of waiting where they're waiting for the results from the radiologist to tell them what's going on. And that's because the radiologist is very busy. So in most cases, the applications that you're seeing for deployment and clinical translation for AI in radiology has really focused on trying to make the radiologist more efficient, so reducing the time it takes them to go through the studies. But what we've decided to do, and what we've found, is that there's a lot of interest from this doctor instead. This doctor could use the tools and actually make decisions right at the point of care if we can provide a contextually aware AI model, in this case, maybe the multimodal data fusion approach, that allows both clinical context and pixel data to inform clinical decision making. And so this is actually the basis of a project that we started with here. This is me meeting Nat Dean, who's the chair of pulmonary critical care medicine. So he's a pulmonologist, not a radiologist. And he's created a tool that uses EHR data to help clinical decision-making around pneumonia. And how does this work? Well, this ePneumonia tool relies on, again, sort of contextual data from the EHR, but also needs to have some of the information extracted from the radiology report of the X-ray, as you can see here. And so what this is essentially is doing is this is kind of a hack around a multimodal data, whereas it takes the report from the imaging studies and not the pixels themselves, which requires a human to create, and then extract structured data from the report in order to create a model that actually can help do clinical decision making. And so when he tried this out in a small pilot, he was able to reduce 30-day mortality in this country for pneumonia by 30%, which is astounding, right? To reduce 30-day mortality by the use of this clinical decision support model. But the problem was that the MD utilization, so no one was really using it. The utilization was 20%. So why was this? Well, it turns out, as I was trying to tell you earlier, that there is still a reliance on the radiologist because this model does not consider the pixels. It considers the report, which is generated from the expert radiologist. So they still have to wait for the radiologist to interpret the exam. And in some cases, that could take up to 6 hours. So no one's going to wait for 6 hours before making a decision whether to treat a patient. So we've actually inserted an AI model, actually as a multimodal fusion model, similar to the approach I talked about earlier, where we're taking, this is actually an early fusion approach. We're taking EHR data that he's already kind of developed and the pixel data together and creating a model that can make a decision right away without having to wait for interpretation. And so the advantages here at the point of care, as opposed to deploying this in the radiologist's room, is that they don't have to wait for a radiologist. They don't have to rely on free text, as is common in some of these problems. And there's no variability that consistency actually helps this model be more useful to the practitioner. And so the given physician on a given day is no longer a consideration. And what we found was in our analysis that our model actually performed as well as physicians for the purposes of analyzing the pixel data. So we felt that the pixel model alone, and then when incorporated with the EHR data and multimodal fusion, we were able to perform at the level of human experts. And this is work done by Jeremy Urban. And so our clinical trial, which is now ongoing in 55 clinics, is actually looking at the difference in outcomes at the point of care with the use of this tool in the workflow. So a multimodal data fusion model that is taking in clinical context and the pixel data to help make a clinical decision. And this is currently funded by the AHRQ. But if we take a step back, we can look at a larger opportunity. So we can see that most of the world, and is often a surprise to American audiences, that most of the world doesn't live in North America. In fact, only 5% of the population of the world lives in North America. So where are we there in trying to address where the population is in their needs? Well, there's a lot of focus on U.S. healthcare, despite the very little of the world lives here, because of the amount of money we spend in our economy for healthcare. And that makes sense from this perspective of someone trying to sell a product. But when we look at impact, we recognize that most of the radiologists in the world aren't in the places where the people are. So there's a huge opportunity to provide access to models like these at the point of care in situations where there are no radiologists to begin with, and the impact is potentially huge. And so when we look at the question of whether AI will replace radiologists, it's actually that clinicians who use AI may replace radiologists or may substitute for radiologists who aren't even there. And we actually tested this out with another multimodal data fusion project. Again, we really need to think about not just the pixel data, the features in the pixels, but the clinical context. And here's a situation where we worked with pulmonologists in South Africa to create a multimodal data fusion model that could identify tuberculosis amongst a host of other problems in HIV positive patients. And because of the fact that they don't have radiologists that are able to staff this clinic, it was a critical need for this group and this patient population, because what was happening is the pulmonologists, who are not imaging experts, were trying their best to interpret the x-rays to make this diagnosis. And so again, we created a model that took in clinical information and the pixel data and created a probability for the presence of tuberculosis so that these physicians could treat these patients. And so this model, which is, by the way, currently available right now on GitHub, you're welcome to explore this, allowed us to present the model to the clinicians right at the point of care in a situation where there weren't a regular radiology group that interpreted for these people. And this is work led by Pranav Rajpakar. So just some quick headline views of this. We found that the clinician performance without assistance was relatively low, below that of a South African radiologist, but this is a very hard task, and I actually took the test myself and found that it was incredibly hard. We don't treat tuberculosis at all in my practice, so it was a new diagnosis for me and very difficult. But we found that with the model, the multimodal data fusion model, together with the clinician, they were actually able to exceed the performance of a South African radiologist, which is tremendous, right? Imagine the opportunity here for these types of models to be deployed and to assist people at the point of care. So it really is a different paradigm shift here. So, that was kind of a whirlwind tour through just the concept of really just to help all of you think a little bit about what else beyond the pixel will help us achieve the standard of care. And when we have achieved the standard of care, where in the healthcare environment do we apply or deploy these models? And I hope that this gave you some new opportunities to think about, both from a global health perspective, but just also in general, workflows that can enable different parts of the healthcare system to leverage these robust models that take in pixel and contextual information to make decisions. So I hope that this was instructive for you. Thank you so much for attending, and please reach out if you have any questions. Thank you.
Okay, thank you, Matthew, for providing the recorded video. Unfortunately, Matthew cannot attend the QA panel this afternoon because his family surprised him with the Father's Day trip. But if you have any questions related to his work or other publication, to his talk or other publications, you can still type your questions in the chat box, and we will forward your questions to Matthew. If not, our next speaker will be Ima Banerjee, and we will start playing her recorded video at 1:40 Eastern time. All right, so let's continue. Our next speaker is Dr. Ayman Banerjee. She is assistant professor in the Department of Biomedical Informatics and Radiology at Emory University School of Medicine. Her core expertise is unstructured data analysis with deep learning and machine representation of image semantics. She published several manuscripts proposing novel methods for radiology text mining in top-tier journals and conferences. I'm really glad that Dr. Banerjee is able to join this session. So she will answer questions by the end of the recorded video. So today, Dr. Banerjee will talk about natural language processing on radiology reports to generate large labels data sets.
Got it. Okay, so today I'm gonna talk. Kind of weird. Anyways, so today I'm gonna talk about the natural language processing methodologies to transfer the textual knowledge into actionable item. And I'm mainly focusing this talk on the radiology, but of course I will be touching different other types of clinical notes too that we can use actually to extract information and make the decision based on the extracted information. So I'm an assistant professor in Department of Biomedical Informatics and Department of Radiology. I have also an adjunct position in Department of Biomedical Engineering at Georgia Tech. So before I move forward with our research, I just wanted to tell you or reintroduce you to the 3 pillars of AI. So if you know that the AI, the current advancement of AI that we are hearing from every different parts of the research, actually standing on 3 big pillars: big data, high performance computing, and algorithm. If one of these pillars is not exist, this whole advancement of AI probably will fall down. And big data is one of the very, very important pillar to support this kind of AI advancement, because in 2020, actually, every human is generating 2 megabytes of data per second. So you can imagine how much data they are generating per year. And this whole thing is going digital. So we are actually pumping data into the system, and AI is actually taking advantage of that and learning more and more inferable knowledge from that data to make advanced decisions. And high performance computing, of course, it's getting faster and faster. And it's predicted that in the exascale computing in 2023, we'll have the supercomputer that will be 100x faster, 10x faster than the fastest publicly ranked supercomputer in the world. And you guys are very well known with the machine learning thing, so I don't have to touch the algorithm. Of course, you guys know that algorithm is also becoming very, very advanced day by day. But all these 3 pillars is actually standing on the foundational knowledge of mathematics and computer science, starting from linear algebra, probability theory, information theory, and statistics, of course. This whole deep learning paradigm actually started with the unsupervised feature learning, because even before deep learning, the machine learning existed. But the only problem was, especially for the images, we have to actually hand engineered features for extracting inferable knowledge from any types of imaging. And especially for the radiological images, it is more difficult because this kind of hand curated imaging or hand curated feature needs a lot of expertise, and experts' time, of course, is very, very expensive. So for example, imagine that we have an X-ray image and we need to predict if the lung mass exists in the X-ray image. So this needs to be processed and extract the information that actually corresponds to the lung mass. And it is not that easy because, for example, a computer scientist will never have an idea just by looking at the image where the lung mass exists, and if what kind of feature is actually corresponding to the lung mass that would be useful for the prediction. And the deep learning actually changed this paradigm completely, especially the convolutional neural network that can process that images through a multiple nonlinear abstraction and extract information automatically and predict the lung mass. So you don't need any kind of manual feature engineering, and it automatically extract the important feature and correlates with the lung mass and achieve amazing performance accuracy. But the only big mantra about deep learning is that you have to go large with the training data. If you have very, very small training data, you can never, probably it's impossible to stabilize a large network that can extract meaningful information for your targeted prediction task. But if you need to go large with the training data, you need a lot of annotation from the expert. But who will pay the annotation? Because annotation is expensive, because expert time is expensive. And it's $1 billion business that to create that annotated, curated data set. And industry, specifically like Google, Facebook, they are paying millions of dollars to collect that kind of annotated data set. So especially if you are in a research or academic environment, it's kind of like impossible to pay that much amount of money to curate a good annotated data set for training your very large nonlinear deep learning models. So if I take a step back and look at the data collection process for the AI model development, you'll see that it's kind of like iterative. So it starts with the data collection, where we go in PACS or whatever medical imaging data set that we have, a database that we have, and we collect the images, we pull the images, right? Then we reviewed the images, and that also needs a lot of time because that needs the data cleaning and everything. But this data review, the data cleaning, the data processing, the data normalization, we can still do it from a computer science perspective, because that is mainly looking at the imaging feature and clean the data, standardize it. But the main difficulty for us as a computer scientist starts from the reader's recruitment and annotation. First of all, the reader's recruitment actually needs a lot of money to recruit the reader and to recruit the experts of the field so that they can do the exact annotation that you need, and to reduce the interdata readability, right? Because if you have a lot of variability between the readers, even if you collected an annotated data set, that data set will have a lot of noisy information, will probably not be useful for your model training. But then the main difficulty is here, that now you have to give the images to the reader so that they can do the annotation. And this is hours and hours of manual job, because specifically if you want to create the outline, or even if you want to create like a image level for your whole study, but still it needs a lot of time from the reader. They have to look at the image, they have to do the particular diagnosis, and other than the image, at that time, they will not have any other information. But in clinical scenario, actually, when they analyze the image and create the annotation, what they do, they will also have all the patient history at the same time, as well as the image, so that they can make a very well-informed diagnosis of that image. But while you are doing the annotation for creating data for the AI model, we usually give the experts only the images without giving any kind of past information about the patient. And that could be sometimes problematic and will create some kind of noisy annotation also. And again, our mantra is still here, that this whole data annotation will need you need to collect a very large annotated data set. But even after creating the annotation of the data set, when we're building the model, we realize that that data set is not enough. So we have to go back and collect more data. And this process kind of becoming very repetitive process. And you have to remember that you need expert labor. It's a very laborious process, it's expensive, and it's never enough. The deep learning, if it's just like pumping the data into a model, right? You always need more and more data for getting a very stable model. But if you go back and look that how the data is actually being generated, that you would see the radiologists, clinicians, pathologists, they're actually looking at the images at the same time they're dictating the report, or they are even writing the reports. So it's already, you have the kind of like manual interpretation of knowledge of that image already documented in the report. But the problem is that these reports are actually free text. So it's written in natural language, and most of the time is very ambiguous. So extracting information for those reports actually needs advanced natural language processing technology, so that you can parse those reports and extract the relevant information for creating the annotation for your images, and which is not a very easy task. And it would be even more interesting that if you can actually create a kind of integration between all these different sources to create the information. For example, if you are analyzing a CT head reports and you have a tumor, if you have the following pathology, it would be nice to actually correlate that pathology information also with the radiology information, generate your final label, which is a very, very difficult task in general. But imagine that everything is done. So we have a natural language processing model, and that can correlate all these 3 defined sources of information to create the annotation. That would be amazing actually for training and machine learning model for this CT image diagnosis, because you will have now correlates multiple level of information and you create the annotation automatically. But the main challenge is that these all reports generated by the clinician, pathologist, radiologist, nursing staff, they are all free text and cannot be directly interpreted by the machine due to the ambiguity and subtlety of the natural language. So mathematically, what you want to achieve is you want to achieve a function around your free text clinical narratives that will generate a vectors. That vector would be a numeric vector, like a numeric embedding of your whole report. So we can use that numeric embedding as an annotation of your image and train it accordingly, because that can be automatically generated from the reports. But then the question comes in that what is the best representation for the documents so that we can capture the semantics of the text so that the machine understands the semantics properly. And this is not an easy task. There are several research has been done on that particular area to create a semantic representation of the clinical text, or even the semantic representation of the natural language. But in radiology, actually, it has a lot of values that if we can use the clinical text to generate the annotation automatically, because currently radiology is using structured reporting, starting mostly from the 2014. So we have for ultrasound, for liver lesion, we have the LIRADS, then we have the BT-RADS for the brain tumors. So we have the ultrasound for the TIRADS, then we have the mammogram for the BI-RADS for the mammogram. What it does actually, it uses the as less as possible the free text reporting in the documents, and finally it generates a kind of scoring for each of these defined study. For example, you can see that for liver lesion, for ultrasound especially, we have 3 types of scoring. Ultrasound 1 is negative, ultrasound 2 is subthreshold, ultrasound 3 is actually positive, like positive for the cancer. And then for BT-RADS also we have, for brain tumor, we also have this kind of similar scoring. So it's actually the radiology is not only giving you the findings, but also gives a structured scoring for each of the study. So it's immensely helpful that if we can extract the scoring, we automatically get the annotation for that particular study, specifically for the diagnosis. And it's kind of like very interesting. But the main problem is that the structured reporting standard has only been introduced in 2014, but we also have a lot of radiology study done before 2014. And for example, like BT-RAD was just introduced in 2017, 2018. So still the structured reporting is popular among the radiologists, but it's not widely adopted sometimes. And we still have the free text report that doesn't have the code. So if we go back and look at the structured report, you will see the structured radiology reports, they have this particular section. So I'm showing here a liver lesion reports, ultrasounds, and you can clearly see that you have a finding section where they clearly describe the findings of the livers, and they also measure the lesion, also measure and document the measurements. And at the end, at the impression, they also gives you a kind of scoring for that particular liver lesion. So it's clear that they mention the finding as well as they mention the scoring of the liver lesion. So it's very easy from the natural language perspective to quickly extract that labels as well as the finding that is necessary for your imaging. But if we look back and look at the similar kind of report, but in an unstructured format, so you'll clearly see that your findings is just like a kind of like text snippet lumped together without any proper findings. So we don't know where are the liver findings, where are the gallbladder findings, where are the kidney findings. So you need a kind of good extraction to extract those information. As well as at the end of the impression, we don't have a standard scoring. So you don't know that what scoring the radiology derived based on this finding. So it's just written in the free text. So it is kind of challenging from the NLP perspective that if we need to access the data from the current study as well as the historic study, there is no easy way actually to use those 2 types of reports and extract the information. So basically what we have to do, we have to derive from the NLP wise, we have to derive a common embedding space where we will be representing both the unstructured report and structured report in a vector format. So probably everybody has an idea about the document to vector. For example, like this model in an unsupervised way learns a vector representation of the whole document. So you give the word vectors as well as the paragraph ID. So you pass through the nonlinear layers, and finally in the output layer, you get a document vector. But the problem is that if you just use the out-of-the-box document vector, you would get some representation, something like that, that the unstructured and the structured reports, they represent in a vector format, but they actually reside two different space, two different areas in the space, that it clears that the information that is conveyed in the structured report and the information that is conveyed in the unstructured report, it cannot be generalizable, that you need some effective technology so that if we train the model on the structured report, it's also generalizable to the unstructured report. So that is kind of project that we are interested in. So we want to create a large annotated data set using all the radiology study that has been done on that particular methodology or that particular protocol. For example, if we are talking about liver lesion, so we want to use all the liver lesion study for ultrasound, and we want to use both the structured report as well as unstructured report. But the problem is that we don't have annotation for the unstructured report. That means the standard scoring for the unstructured report. So our whole idea is that we will train the model only on the structured report, and we will use all the unstructured report that doesn't have the scoring, and the trained model will be used to extract the scoring from the unstructured report. So what we will have at the end, a large annotated data set with both structured and unstructured reporting with the standard scoring. So now, if we can automatically generate those kind of reports, those kind of scorings, so you can imagine that we can train a very complex deep learning model without any problem and without automatic annotation. We don't need an expert annotations at that stage, and that will save you time, labor, money, and everything. So our methodology actually combines the natural language processing, deep learning, semantic reasoning, and domain knowledge together in an iterative way again to extract those kind of labels from the free text reports. So we actually have a patent on that. The whole idea is that we are using the free text as well as we are using the NCBO bioportal. We developed a small Sparkle-based system, OntoCrawler, that goes inside the NCBO bioportal, and given some key terms, it can extract a sub-dictionary for the perfect domain. So for example, if you are working on the liver cancer, you can easily search for the key terms in a corpus of your clinical notes, and then you can query the bioportal to extract the sub-dictionary for your domain. So which will include all the synonym subclass of your key terms and will generate a very comprehensive domain to standardize your space, because you know that structured report, they use a very kind of like templated document, but unstructured reports, they use a lot of synonyms. And it has been historic reports, so the language changed a lot. So we want to actually normalize the language space in such a way the structured report and unstructured report creates a uniform embedding space. So then we actually developed a report condenser, which is kind of like standard pre-processing NLP step that reads the report, cleans it, condenses it. Then we also have a clever dictionary which stores all the regex related term, the risk related term, the affirmation term, and their synonyms. It is also created through the distributed semantics approach. And finally, we actually use both the clever as well as the domain specific dictionary to create a kind of semantic dictionary mapping. So semantic dictionary mapping step, what it does, it actually reads the free text reports and replace the term with the root term so that we normalize the language space. So once we normalize the language space, we can create the neural word embedding in an unsupervised way. And finally, we can create a context-aware visit vector because we already know the key terms that is we are mainly interested in. So we just look at the key terms and their surrounded area to create the context-aware visit vector. Basically, what it does, it creates the vector representation of the whole report. And now we have the embedding space of the unstructured and the structured report in a normalized way. So in that case, you will not have that kind of situation where the structured and unstructured report will live in two different arenas of your embedding space. So these are the main components, the semantic dictionary generation and unsupervised embedding. So we show the first use case where usually you know that this kind of embedding space has been trained on millions of reports. But what we did here that we only trained on 10,000 reports, and we now tested on 1,188 reports from CT reports from the head. it's for the hemorrhage. And we already see that when we create this kind of report representation, all the high risk report are clustered in one side of the space. Low risk report, medium risk report are close to the high risk report, and low risk report are scattered all around the space. So we already know that this kind of semantic embedding even works with a very small amount of data. As well as we also tried the generalization. So what we did is, this is the Stanford data. So what we did, we trained the model on Stanford, only structured and unstructured report from Stanford. We tested on Stanford as well as we tested on Duke. We clearly see that the embedding holds the language space that has been learned on Stanford. It also holds for Duke. And for this case, actually, we outperformed a rule-based system that was actually developed on Duke dataset. So which is kind of interesting. And then we also show the kind of like transfer learning, where we train the model on the ultrasound language space, and we fine-tune the model on the MR language space. And we can clearly see that the ultrasound and MR, they are overlapped nicely. And the new words that appear in MR, they also learn the synonyms also from the ultrasound language space, which is kind of interesting. For example, like bright, isointense, hyperintense, hypointense is also recognized as a kind of like synonyms or similar words of the bright. So which is kind of interesting. And we apply that kind of semantic embedding technology in multiple domains in radiology, starting from CT, MR, ultrasound, mammograph, for different kind of use cases also. And we also did a lot of clinical applications, starting from cancer recurrence, patient-centered outcomes, survival analysis, and we have results for each of these, but I don't want to go into too much detail of each of these case studies due to this time limitation. But I would show you a few interesting results. For example, first is LIDARs, where we actually trained the model again on the structured data, and we propagated the LIDAR score for all the unstructured data. So we actually did it to generate a large data set, annotated data set for images. But what we see that the radiologists, they are also using it to track the patient, because now we, for example, for this patient has started their screening exam from 2007 and till 2018. But only in 2017, actually, we have the introduction of the LIDAR standard, but they have all the reports even before the LIDAR standards were appeared. But now we can actually assign automatic scoring. So we can actually track the patient even before the LIDAR standard was established. So you can clearly see that the patient had the LIDAR score 1 till 2016. Suddenly it went to LIDAR score 3. And also for MR, we see the same trend. So it's kind of like interesting that we can track the patient automatically now. And we also did this kind of study where we propagated the LIDAR score for the 10 years of ultrasound screening study. And we show that why the ultrasound missed some of the cases that was actually had cancer diagnosis in California Cancer Registry, but the ultrasound missed the cases because of it was technically limited, or it had a cirrhotic liver, heterogeneous liver, something else. And we also test the generalizability of the model, that we train the model on the Stanford data, we tested on UCSF data, and we clearly see that the model retained its performance. The performance was very high. So similarly, we also annotate the 10 years ultrasound data from the UCSF, and we see kind of like similar distribution as of Stanford for the 3 categories, ultrasound 1, 2, and 3. Then we also compare the NLP model with the radiologist assigned performance, and we clearly see that the performance was quite high for the cases where the patient appeared in California Cancer Registry. We can clearly see that the NLP and radiologist performance was quite similar. So actually the NLP performed quite high for predicting the LIDAR score efficiently. So one of my students, actually, he also developed a thyroid kind of like similar approach for thyroid nodule. So, but here the only interesting thing is that, so he also used actually the other types of data, not only radiology reports, he also used the age, gender, race, as well as the clinical indication to create the reports, the automatic scoring for thyroid nodule called ThyRES. And he also developed a graphical user interface where, given the nodule description, the model can automatically predict the ThyRES score. So which is also kind of interesting, following the similar idea. And he also tested it on Emory internal validation dataset, as well as a prospective dataset for Emory, as well as on the Stanford dataset, and show that the performance is actually generalizable. So which is kind of, again, very interesting results. So not only radiology report, we also try to merge the radiology report, pathology report, as well as a progress note to create the labels for the recurrence. So we are mainly trying it for the breast cancer recurrence. So we actually divide all the clinical notes of the patient appear in one quarter. into the text snippets, and we predict the recurrence for each quarter. So it's not only predict if the patient has recurrence, it also identifies exactly at which quarter the patient had recurrence. So it also extracts a kind of like timeline of recurrence. And we compared that model with the rule-based method that was previously developed and published. And we see that rule-based method actually works pretty well, but some condition that, for example, a tiny metastatic focus, difficult to exclude, this kind of cases where it is difficult to exclude, so it's not confirmed. The rule-based predicted it as distance metastatic present, but actually the ground truth was there is no metastatic because it was not confirmed. But our model actually can efficiently predict that, because, for example, that worrisome of metastatic, you see that this dark color represents the higher weight. So worrisome of metastatic gets higher weight even than metastatic. That means the model can understand the vagueness of the language even, so which is kind of interesting. And similar to our latest study, we also define a kind of timeline of the patient where we read the radiology, pathology, and progress report from each of the quarter, and we are predicting when exactly the patient has recurrence. And we also extracted the text snippet for the recurrence. And now, since we have the recurrence level, we can slice and dice the data set as we want. So we actually first extracted all the tumor grade information and we correlate it with recurrence. We also extracted all the tumor receptive information and correlate with recurrence. And it was pretty interesting to see that the power of NLP, that the whole 10 years database, we can slice and dice as we want. So kind of like interesting approach here. So we also analyzed the generalization of this method. So we took the prospective breast cancer dataset and the performance was still the same, 0.9 AUC. We also validated it on the liver cancer dataset, which was not how the model was initially trained on. And we see the recurrence performance was quite high also on the liver cancer. Then we compare our NLP performance with the cancer registry data as well as the ICD-9 code. So we can clearly see that in the ICD-9, the model actually, the NLP model added more patient compared to the performance of the ICD. Just a second. Sorry. Yeah, so compared to the ICD-9, the model performance was quite high, because you can clearly see that the model added additional 474 patients, which was not captured by the ICD-9. So which is kind of interesting that even if we use the standard billing code, it's still actually our NLP model outperformed the standard billing code. So which is kind of interesting. And as I said, that the model was only trained on identifying the distance recurrence, but when we plotted the probability of the predicted probability of the model for the distance as well as the local recurrence, we can clearly see that the model has a high difference between the distance and local recurrence. The model can even understand that that language actually represents the local recurrence compared to the distance recurrence. Again, for the liver, we have the similar finding that even if the model is not trained on local recurrence, the model can easily identify the local recurrence. So we just extend the model to also identify the site of recurrence. So once the model predicted is a recurrence positive, so we have a kind of a decision node. So all the no recurrence model we just drop, and that goes to the other 7 defined model to predict bone, liver, lymph node, lung, skin, CNS recurrence. And we see that the model achieved very high performance also for identifying the site of recurrence. That for liver, for breast, we got very high specificity and sensitivity for identifying the site of recurrence. But our main question still remains that, okay, the NLP model achieved the high performance for extracting the annotations, but can we use it for training the imaging model, which was our goal from the beginning, that create a large annotated data set for training the deep learning model. So the first experiment that we did is we curated this recurrence and no recurrence data set for mammogram in Stanford for 10 years. And then we run a very simple CNN model with attention to predict the recurrence and no recurrence. And we compare that performance of NLP curated weekly level data with the manually curated data. And I'm going to show you the results here, that the baseline method is only using all the manually curated level data, which is less than 10,000 exam. We achieve like 0.73 AUC. But then we added more than 80,000 exams with NLP curated levels. So NLP curated levels, they have a high performance, but it's not like 100% accurate, but still we got a huge performance boost when we actually augment the data with NLP curated levels. So similar thing, not with only with imaging, we also tried it with predicting the recurrence within the 1 year using only the structured and unstructured clinic notes. So you can imagine one patient has multiple different types of visit, and we want to predict, starting from this time point, if the patient will have recurrence or not. So there can be two different situations, that one patient can have recurrence, one patient can not have recurrence. But the problem is that all these patients will have very different heterogeneous types of visit, and those would be like very differently spaced between the visits. So we developed this kind of pipeline, again, following the similar technology that I described before, that we have the text cleaning, but here the text cleaning, the neural embedding training, other than using only our in-house dataset, we are also using some open source dataset like I2B2 Mimic3, and we actually just want to incorporate as much as knowledge as possible for formulating that language space. And then after the document vectorization, we are actually using 3 different kinds of model. So first is traditional supervised, where we're using only the manually curated data. Then we also have highly supervised model, the weakly supervised model, where we are using high specificity. We want to increase the specificity. Then we also have another weakly supervised model where we are using the NLP level with high sensitivity. So these two kind of interesting, because we want to see that how the weakly supervised NLP model can help the model training. Does it need only more data, or does it need more efficiency in the model, or efficiency in the accuracy of the prediction? So that's a kind of like interesting thing. And we trained the model on 8,956 de-identified breast cancer patient data from Stanford. And this is a very simple longitudinal model where we have 2 layers of stacked LSTM, where given each of these encounter representation, we are predicting if the patient will have recurrence or not. So this is a kind of results that I want to show, that the red line actually signifies the recurrence status of the patient, and the blue line actually signifies the predicted probability by our model. So you can clearly see that the blue line closely follows the red line. That means the model has a good trend of the prediction for the recurrence. And this is a kind of like comparison that I want to show, that only using manual annotation, again with a small less than 1,000 data set, we got 0.84 AUC ROC. But when we use the manual annotation and NLP generated annotation together, we had a performance boost of 0.94. And this is the result for the weak supervision 1 and 2. We can clearly see that increasing the sensitivity, we get the good performance. We get more performance boost compared to the high specificity. That means more data, even with less performance, actually, we get high performance compared to the AUC ROC, but the sensitivity and specificity is almost the same for that LSTM model. But then we compare that with the traditional model. We clearly see that traditional model, even using the NLP, performs quite well compared to the baseline, but we had a performance boost with the longitudinal LSTM model that can retain the historic data of the patient too. And in summary, before I conclude my talk, I just wanted to mention 3 important points. The deep learning model, the deep prediction model, works always better with a large data set, even with a weak level compared to the small expert curated data. And NLP tools are very powerful to generate such large annotated data set for medical imaging. And the only thing that we are missing now compared to the literature, that we need the tools to combine the multi-source data for curating the meaningful annotation, because we either depends on only on the single source like radiology or pathology or the clinical notes, but the whole field is going towards that direction, that we need to combine multi-source data to curate the meaningful annotation. And that's it. I will conclude my talk here. Please feel free to ask me anything. Thanks.
All right, thank you again, Emma, for preparing this recorded video. So any questions from the attendants? I think Dr. Banerjee will be happy to answer any questions. So Iman, are you there?
Yes.
Okay. Will you attend the QA panel later?
Yeah, sure.
Okay, because I have several questions, but since we are a little bit out of time, so I think it's better to ask you the questions during the QA panel session.
Okay, makes sense. Thank you.
Okay, thank you, Ima, again. And thank you everyone again for attending the first part of this tutorial. And we already spent more than 2 hours on this tutorial, so we'll take a short break, and we will be back at 2:30 to we will have 2 more tutorials in the second half, and then again at 3:30 each time we will have a panel discussion. So we will be back in 40 minutes. recording. Our next speaker is Ying Zhu. She is assistant professor at the Department of Computer Science and Engineering at the University of Texas at Arlington. Her research lies in the intersection of machine learning, computer vision, medical imaging analysis, and bioinformatics. She has published many papers in top computer vision and medical imaging conferences and journals. Today, Dr. Zhu will talk about the interpretable deep learning model for multiple modal and cross-domain medical images. Okay, here we go.
Hello, everyone. Welcome to our tutorial about leveraging the NLP for radiology imaging analysis. So, before starting my tutorial, hello, everyone. Thanks for joining us for the tutorial about leveraging the clinical notes for radiology imaging analysis. So, in the recent 10 or 5 years, deep learning has been shown very impressive performance on the medical imaging data analysis. However, the performance of these deep learning models depends on the availability of the large-scale, high-quality labeled medical imaging datasets. For example, here we show some different types of medical imaging examples. For example, we have the brain imaging, we have the cardiovascular imaging and chest CT and chest X-ray, and we also have the pathology images. So far, lots of public available medical imaging datasets focusing especially on the brain imaging. For example, there are a lot of available brain imaging datasets. This one is called ADNI. So ADNI is like a very large-scale dataset focusing on the Alzheimer's disease diagnosis. And this one is another one is also very popular. It's called Autism Brain Imaging Data Exchange, which is also a very large-scale brain imaging datasets for the autism diagnosis. And besides that, we also have the ABCD dataset, which is a large-scale dataset for focusing on adolescent brain development. And another large-scale dataset available is for UK Biobank. UK Biobank is also including a lot of like Alzheimer's disease brain imaging. And besides that, it also including a lot of like chest X-ray and chest CT. So besides the brain imaging, other large-scale medical imaging datasets, like focusing on the chest and abdominal, most popular one are these three datasets, chest X-ray datasets. First one is NIH chest X-ray, which is the first released for diagnosis of the different lung disease, different chest disease using the chest X-ray image. So they have released the 14 labels and follow the NIH chest X-ray. There are two datasets which called Mimic chest X-ray and Stanford chest X-ray. So these two datasets are also following similar format and pipeline like the NIH chest X-ray. So and besides the chest X-ray, another very large-scale available dataset is called deep lesion. So deep lesion is also recently released back into 2018. So this dataset is very large-scale and was also focusing on different types of lesion, especially in focusing on the chest area and abdominal area. So besides this dataset, actually. Instead of only have the CT and chest and X-ray. The modality is just CT and X-ray. So actually, in radiology imaging, another modality, the MRI is also very popular because, as we show example here, for example, we have we have X-ray, CT, and MRI of a banana. So if you look into this image, you can say like CT compared to X-ray shows more details in the inner structure of this banana, and the MRI shows more fine-grained structure details of the banana. So, especially MRI are very important diagnosis imaging used for the detail for the detailed for observing the detailed structures relevant to different disease. So just to compare the MRI to CT or X-ray. So far, a lot of public available data sets focusing on the brain MRI, but very limited data sets focusing on the body MRI. And actually, usually CT images are when the patient is taking a CT scan in the hospital, they're usually focusing more on the large range and with less details. And when the patient is taking an MRI scan, usually we're targeting a small areas and with more details. So in one sentence, it's like a MRI shows a body MRI usually shows a strong deformation because of this changing in the of the different organs in the body and in abdomen and chest, and also it has more complicated pathologies and more complicated anatomies. So in our recent work, actually besides the CT and chest and X-ray, we're actually working on creating some large-scale MRI datasets, focusing on different types of lesion. Especially this MRI will be focused, besides the brain MRI, especially this MRI will be focusing on the chest and also abdominal parts. Just back into deep learning work. So most of deep learning that requires the dataset to having high quality labels. So usually these experts sitting there to labeling this image to assign pixel level mask and assign these labels. Actually, this is very hard to it's very hard to connecting such kind of large scale data if we require the expert to labeling that due to the expensive cost and also time expensive cost. So so one idea is like since we were having like in the hospital, we were usually having the MRI scan, and we also will having the clinical reports written by the radiologists or physicians describing the information seen from the images. For example, here we show examples of an MRI scan, and then here we also show the clinical reports associated with this MRI scan. So it basically says this is hyper intense, and this is a lymph node. So, and besides that, in this report, they're also having a coordinates of 4 points from the response evaluation criteria in the solid tumors. Basically, they have been created the 4 points, which shows the large dimension and the longest dimension and the shortest dimension of the lesion. So based on this clinical reports, our ideas, instead of like asking the expert to labeling image, we want to creating the automatically labeling, automatic labels from the clinical reports, and use this to do different tasks of the MRI-based diagnosis, like the lesion detection, lesion labeling, and lesion detection, lesion labeling, and lesion segmentation automatically from this clinic notes constructed labels. So just show this example. Actually, if we want expert to labeling this, it's very time consuming because we need to asking them to draw this contour and also to assign different types of disease labels. So, but if we since we have this 4 coordinates, which measures the dimension of the solution at different dimension of the solution, like longest dimension and shortest dimension. So we can generate some mask actually based on these 4 points automatically, and to generate some like generate some labels for the image. So our idea is like how we can extract the image labels from the clinical reports. So firstly, we will focusing on the small data sets which only focusing on the lymph node detection. So for example, here is this is the reports, and this is actually the label we extracted. So this label is basically describing the different subtypes of the lymph node relevant to this image. And besides that, we also have these 4 points. We can also generating this mask based on this location of 4 points by using like GraphCADs. So in our work, we were working close. We're working close with radiologists and physicians to help us to extracting the labels. So we firstly selected some high frequency. After pre-processing the clinic notes, we selected some high frequency keywords, and then from this high frequency keywords, we send these keywords to the radiologist and asking them to select the most important keywords. And after that, based on their selected keywords, we design a rule-based keyword and rule-based label extraction methods from the reports to extracting the labels. So here, in this small data set, we actually extracted these different types of lymph node labels. And after we extracted labels, as we say that in these reports, besides these labels, we're also having this RECIST, which measures the dimension of the roughly dimension of this lesion. For example, measures the longest dimension and shortest dimension of lesions. So based on this measurement, we will also using the GraphCAD to generating some saddle mask. So, and based on the saddle mask, we also just based on this roughly saddle mask, we propose a global local attention networks with multi-task uncertainty loss to training a model which is able to doing the segmenting and detecting these lesions. So here's this is the proposed methods based on the extracted labels. So the input of this is CT scan, and we have used different backbones to extract the features. So in our work, we're just trying to use the ResNet 101 to extract the features. And then we just follow a Mass-Carson framework. So we extracted the different regions of feature maps. And for the different regions, we having the classification loss. Basically, this classification loss will predict the labels for the lesion, and the regression bounding box will predict the roughly bounding box. And for the segmentation map, we have multiple attentions because the RECIST bookmark generated saddle mask are not very accurate masks. So we have in this multiple attentions weights to improving to adding more uncertainty on our trained model to make our model more robust to different testing case. So we have compared actually our results for different two different baseline models. For example, we have several baseline models: ULO, V3, Phosphorus, and Mass-Carson, and also the detection RS and the casucate RC, and we have 2 models. So first model is trained with the saddle mask and the bounding box generated by the RECIST, and second model is just trained with the RECIST, which is only for detection results. So when we compare our results to all these models, we show like by using this multi-scale attention uncertainties, our models can improve a lot compared to the compared to several state-of-art methods. And here I will also show some like detecting results. So the yellow box are the ground truth, the green box are the predicted one. So and besides this in segmentation and detection, actually we further trying to do something to leveraging also the knowledge graph or autonomy graph, predefined knowledge graph and autonomy graph to improving the lesion classification results actually. So this is a autonomy graph generated by the radiologist, which shows the different relationships between the different subtypes of lymph node. So so to further improving our results, we propose the methods to leveraging different modalities. So first, we have in MRI images, we were using the backbone and CNN to extract the features, and then we do disease label pooling for the features to extract the different lesions label, different lesions image features, and then we also since we also have the clinic loads, so we can training the for different labels for different labels, we can also training label encodings based on the clinical loads, measure the similarity between the different labels. And based on this images features, we will construct two different graph to modeling their relationships. And besides that, we also will extracting the knowledge graph and autonomy graph and combine all these graphs to dynamic learn intrinsic graph structure, and using this graph to predict the final lymph node labels. So we have compared our results to the to several baseline models. So we have actually our model. We have two types of in our model. We have two types of models. First one is GCN with the graph structure learning and knowledge graph, and second is we also use hyper GCN, hypergraph convolutional neural networks. We call it hyper GCN, and with structure learning and knowledge graphs. So we compare to several baselines, show like our model by leveraging this knowledge graph, we can improving the performance significantly, which also shows the importance of using the predefined knowledge graph, especially for medical imaging classification task. So so far the first part we're showing is just a small data set focusing on the lymph node detection. So actually, we are current work. We also are trying to perform the similar task to construct a universal lesion extraction on the MRI dataset. So our work will also similarly will automatically extracting the lesion labels from the MRI clinic reports, and we also will constructing the ontology or knowledge graph for lesion pathology, region, and attributes. So for this universal lesion extraction, the structure of label is actually more complicated compared to the lymph node detection. So here we show some examples. So this is a MRI scan, and then with the RECIST, which is measuring the lattice dimension of this lesion, and the clinical report shows like and in this work we defined this labels, three types of labels. The first types of label is called pathology. And second label is called region. Region basically measures the location of this lesion, measures like the body parts. And then we also have another types of labels which called characters. So characters measures like the different attributes of this lesion. So this is also for extracting these labels. We also first extracting some keywords based on and then sending these keywords to the radiologists and the physicians, and they will selecting the most important keywords. And then based on their selected keywords, we design a rule-based methods to apply to these reports to extracting these keywords. So this is another one, which the clinical report shows like, and we're also extracting the labels, and pathology is complex crest, and regions shows left kidney, and this is another one. This is another. This is an and this is another case, which we have in the region is abdominal wall and character is enhancement. So, and this is another case, which shows is like the pathology label is also complex crest, and region is kidney in lower pole, and the character is hyperintensity. So in this universal lesion detection dataset, we're actually extracting a lot, much more labels compared to the lymph node detection. So here's a table shows the overall labels we extracted. So we're having all these different pathology labels. So for the lesion, we're having these labels, and for the lymph node, we're having these following labels. And for region labels, we're having the different types of regions, mostly focusing on the kidney and liver. And for character labels, we have selected these following character labels. And our next work is we will try to constructing ontology and knowledge graph for lesion pathology and region and character, and from this clinical notes. And also we also want to leverage in the biomedical literatures and existing medical knowledge graphs to make a more comprehensive knowledge graph for us to use. Sorry. So actually, besides extracting the labels from the clinical notes and use it to supervise the image task like segmentation on image classification task. We also are currently working on the medical imaging captioning, like the automatic generation of medical reports from the radiology images. So far, we're first starting working on the chest X-ray. So basically, the input is a chest X-ray image, and output will be the clinic notes. So here's one example shows the chest X-ray and its clinic notes. So we propose a model. We propose a model basically modified from the transformer for chest X-ray report generation. So firstly, for the chest X-ray images, we will using the backbone CNN to extract the features. And then because the chest X-ray images usually they will have multiple labels. So for each label, we will learn we were using transformer layers to learn an embedded features from the extracted CNN features. And then from extracted CNN features, we're using a multiple state multi-head attention to further learn the attention between the different labels. And then based on this latent labels attention models, we will go to transformer decoder layers to output the report. So in this label state multi-head attention, we will learn a latent label embedding layers to encoding the different relationships between these labels and their label associated uncertainties. So so here's some results. Shows we have evaluated our results on 2 datasets. One is on OpenEye datasets, on focusing on general chest X-ray relevant disease, and another is public available CoVOD datasets. So here's the input image, and this is the predicted clinic notes, and this last row is the reference, which shows which can be considered some sort of ground truth for the clinic notes captioning. So if we have highlighted the keywords, extract the keywords which shows which can be used to compare the 2 different clinic notes, the generated clinic notes and the reference clinic notes. So in the future work, we will also further improving this work back to the CT and MRI clinic notes generation, and I think that's the most powerful of my tutorials. So, and also I want to add some information that in our lab actually we have the PhD position available. So the research direction will be on try to learning the visual and the semantic representation for the medical imaging, and also how second research direction will be medical imaging visual question and answer, and the third research direction in my lab is to do the 3D reconstruction from multiple spectral imaging and multi-sensor data. Especially currently we're working on the thermal imaging 3D reconstruction, and also millimeter wave radar sensor data segment, the 3D sensor data, basic object detection and object segmentation task. So if you're interested, please contact with my email. And thanks for everyone's time. And I'm ready to take some questions. Sensor data.
All right, thank you, Ying, for preparing the recorded video. Dr. Zhu is traveling. She just told me that she should be able to attend our QA panel session via phone. So if you have any questions, feel free to type it in the chat box. So I will be the last speaker for today's tutorial, and I will play the video at 3 o'clock, which is just 1 minute. So I will be the last speaker. I'm Yifan Peng from Cornell Medicine. My main research interests include biomedical and clinical natural language processing and medical image analysis by courtesy. But today I'm going to talk about the clinical NLP powered data extraction on chest X-ray and CT reports.
Hello everyone, this is Yifan from Weill Cornell Medicine. Today I'm going to talk about clinical natural language processing and deep learning in assisting medical image analysis. The motivation of this talk is quite straightforward. In the general computer vision domain, we have seen a great use of neural network and deep learning techniques on different image processing tasks. For example, image classification, object detection, or caption generation. One reason is that there are a number of big annotated image datasets that are publicly available, such as ImageNet or Microsoft Cocoa. But in the clinical domain, we haven't seen the same level of success. This is partially because there are less large annotated medical image datasets to fulfill the data-hungry needs of deep learning models. On the other hand, we know that hospitals have already accumulated a large number of raw images, such as radiographs. So the problem we want to address here is how we can construct a labeled medical image dataset to fulfill the data-hungry deep learning needs. For nature image annotation, we can use crowdsourcing. For example, we can given a picture on the left, we can put it online and ask what is in this picture. Then we know that there's a cat. But this crowdsourcing approach for collecting nature image labels is not applicable for medical images. There are a couple of reasons. Number one, it usually requires domain knowledge to annotate medical images. For example, when you see the chest X-ray on the right, I guess fewer people, unless you are a physician or a radiologist, fewer people will know whether there's a cardiomegaly in the chest X-ray. And number two, there are also issues of security or privacy. It is much harder to put medical images on the internet and ask people around the world to annotate them. So both of these reasons make it very hard to construct a labeled medical image dataset. What alternative way we can look into? So the answer is clinical reports. We know that all medical images have clinical reports that are associated with them. So if we can find a way to extract the information from the clinical reports, then probably we can automatically construct a weakly labeled medical image datasets. So here I want to show you an example of chest X-ray with its report. The report says cardiomegaly. Findings include cardiomegaly, otherwise normal lungs and contours. There's no evidence of focal bone lesion. So from this report, if we can extract the findings, for example, the cardiomegaly, then we know the label of the chest X-ray on the left, which is the cardiomegaly. So based on this idea, in this talk, I will present two projects or two directions. In the first project, I will describe a Ruby system to extract findings from radiology reports and show how we can use the NLP, the clinical natural language processing techniques, to construct a large-scale chest X-ray dataset. And in the second project, we want to extract not only the findings, but also the attributes that describe those findings. Some examples of attributes include the size of the finding, the location of the finding, or the severity of the finding. So I will describe how we use a deep learning-based methods to extract those attributes to construct a label dataset with richer information. Now let's talk about the first task. The first task is to extract findings like cardiomegaly from the reports. But if we simply apply name entity recognition tool on the reports to extract all findings, we will also extract the lesion in this reports, from these reports. Then we create a mistake because the report says there's no evidence of focal bone lesion in the image. So here we call the cardiomegaly positive findings and we call the lesion negative findings because it is ruled out by the radiologist. And we definitely want to differentiate the positive findings and negative findings. Otherwise, the downstream applications like image retrieval may return many irrelevant results if we did not distinguish the positive and negative findings. We read a lot of radiology reports and find that there are much more negative findings in the clinical text than from the general text. More formally, we call a finding negative if it is ruled out by the radiologist, such as no evidence of focal bone lesion or clear of acute infiltrates. Besides negative findings, there are also a lot of uncertain findings. Here we call a finding uncertain if the radiologist is suspicious of that finding. So some examples include possibly small left pleural effusion or may represent small nodules. So those are uncertain examples of uncertain findings that we observed from the radiology reports. Therefore, the natural language processing task here is to differentiate the positive findings from the negative findings and uncertain findings. Here I want to describe a two-pass approach to achieve this. So in the first pass, we use the name entity recognition tools to detect findings from the reports. At this stage, we simply extract all findings. We don't care whether they are positives or negatives or uncertain. And there are many name entity recognition tools that we can use. We can either use a rule-based recognition tool with a control vocabulary, or we can use some machine learning-based methods to detect those findings from the reports. And in the second pass, we differentiate negative and uncertain findings from the positive ones. And here we can apply rules on universal dependency graphs to differentiate them. I will describe more details in the next slides. The universal dependency graph contains vertices and edges to represent the syntactic and the semantic information of a sentence. Vertices are words or phrases labeled with information such as a part of speech or name entity mentions. So in this case, in this sentence, lungs are clear of acute infiltrates or pleural effusion. Lungs are clear of, or they are words in the graph. And the acute infiltrates and pleural effusions are two phrases. They are also vertices in the graph. And these two phrases can be detected from the name entity recognition tool I described before. Besides vertices, there are also edges to represent type dependencies from one vertex to another one. So for example, there's an edge from the words clear to the words lungs with a typed dependence n subject. It means that in this sentence, the word lungs is the subject of the sentence. We also have the conjunction or coordination construction in this sentence. So from the typed dependencies, we also know that the phrase acute, infiltrates, and pleural effusions are coordinated with each other in this sentence. And those information is very helpful when we apply the patterns on the graph. After we get the graph, we can define patterns to differentiate the positive and negative and uncertain findings. For example, we can define a pattern clear of something, and we apply the pattern on the graph. And we find that the pattern match two phrases at the same time. Then we know that both aqueous infiltrates and pleural effusions are negative mentions or negative findings in this sentence. And through this process, we can distinguish the positive and negative and uncertain findings. From this example, we can also see the reason or the motivation of using dependency graph rather than the surface text to do the distinguish. This is because by using the syntactic or semantic information, we can use less patterns to capture more text variations that cannot be done by using only the text surface with regular expression. So in this example, we only need one pattern clear of something, and that pattern can simultaneously applied to two phrases in this sentence and extract and do the detection. Otherwise, if we use a regular expression, this task is quite a challenge, because if we want to detect whether the pleural effusions is negative or not, we need to skip the words between the clear and pleural effusions, and we don't always know how many words we need to skip in the sentence. Here I want to show you several rules that are frequently observed in the radiology reports. For negation findings detection, the most common rules are no disease, without disease, clear, free, or disappear of certain disease, or without evidence of disease. For uncertain findings detection, the common rules include cannot exclude, concern for, could be, maybe, or difficult to. So those rules are frequently appeared in the radiology reports. We name the methods NACBEL, and we make the code and rules public available. We hope that other institutions or other researchers can apply our tool on their own or on their in-house datasets and release the weekly label datasets to the public. We hypothesize that the release of the labels will be easier than the release of the whole reports because of the protected health information embedded in the radiology reports. We also applied our tool NACBEL on the NIH access3 datasets to generate labels. So this NIH access3 dataset consists of more than 100,000 frontal view X-ray images with 14 common lung diseases annotated by the rule-based system. We released this large-scale label dataset in 2017 with the hope that the academic or research institutions across the country will be able to teach a computer to read and process X-ray. Besides NACBEL, there are other NLP tools to extract the findings from the radiology reports, and there are also other large-scale check X-ray datasets that make public available in recent years. So here I listed two famous check X-ray datasets. One is CheckSperts, which was developed and released by the Stanford group, led by Matthew, who is the speaker, one of our speakers in this tutorial. Their group developed the CheckSperts labeler, which is also a rule-based system built on top of NACBEL. They also developed a deep learning-based methods, a BERTS-based methods called CheckSperts to detect the 14 common lung diseases from the radiology reports. The other data set is called Mimic CXR database. It was developed and released by Johnson, who is also one of our speakers in this tutorial. So taken together, we have at least 3 large-scale check X-ray datasets with high quality labels of 14 lung diseases. And through this process, we have already seen a big improvement of using deep learning to detect lung diseases from check X-ray. This is how we can use NLP techniques to extract the findings from the radiology reports. In the next steps, we want to extract not only the findings, but also the attributes that describe those findings, such as the finding size or its location. So in this way, we can probably construct data sets with richer information, and we believe such richer information will be more valuable for medical image analysis. Therefore, in the second part of my talk, I will describe a work that uses deep learning method to construct such data sets with richer information. To show how those attributes can contribute to the image analysis task, let me first give you an example of lesion images retrieval. The image on the left is the query image, and the images on the right side are the retrieved images. Here we use not only the image, but also the attributes like right, which is the location, or rib, which is the body part. We use those attributes to help us retrieve images from the database. From this example, we can see that we can retrieve more diverse images that are not similar to the query image, but share the same semantic meaning. From the previous example and many others, we know that the attributes in the clinical reports, in the radiology reports, are also very important. So now the question is how we can utilize the NLP techniques to extract those attributes that describe the findings. Let's take a CT image and its reports as an example to demonstrate the relation between the reports and the image. In the CT image on the left side, there is an area of interest marked in green. The radiologist then wrote a sentence to describe this green box. The sentence says, within the right middle lobe, there's a stable nodule that measures this size. And then the radiologist will link the sentence to the box by inserting a bookmark. It's also marked in green. So from this bookmark and the sentence, we know that the type of the bookmark is a nodule, and its location is within the right middle lobe of the lung. So in this project, we call the right middle lobe and nodule the attributes that describe the bookmark. And the task is to extract them from the radiology reports. If we use the name anti-recognition tool to extract all attributes in a sentence, we would make a lot of errors. So first, there might be multiple bookmarks in one sentence. Like in this sentence, long plural, smaller dependent, left plural, modularity, for example, bookmark A, and periodic, bookmark B, the smaller junction, possible scaring, bookmark C. There are 3 bookmarks in this sentence, but we are only interested in bookmark C because it links to the CT image on the left. Therefore, the first challenge here is to find which attributes describe which bookmark. Like in this example, the left plural modality or modularity, they describe the first bookmark, but not the bookmark C. Second, there are also uncertain attributes mentioned in the sentence. Like in this example, it says possible scaring. So it's uncertain attributes that describe bookmark C. Therefore, the challenge here is to differentiate the relevant with the irrelevant and uncertain attributes. So in order to do that, in order to differentiate those attributes, we treat this problem as a relation classification problem in natural language processing. So we first create all pairs of bookmarks and attributes in the sentence. And then for each pair, we use a deep learning model to judge if the relation between the bookmark and attribute is irrelevant or relevant or uncertain. Like in this example, we have 3 bookmarks and we have 5 attributes. So together, we have 5 candidate pairs for bookmark C. And for each pair, we use a deep learning model to judge whether there's a relevant relation or irrelevant relation or uncertain relation between bookmark C and attributes mentioned in the sentence. Our approach therefore consists of 2 steps. In the first step, we use the name anti-recognition tool with the ontology to extract all the attributes from the radiology reports. And in the second step, we use a transformer-based model to distinguish the relation types. There are many deep learning-based methods or other machine learning-based methods that can do the relation extraction or relation classification. Here, I just want to emphasize that for this problem, the input is a sentence with the attribute and the bookmark annotated, and the output is a 3-class label, which are relevant or irrelevant or uncertain types of relation between the attributes and bookmark. Because of the time, I will now talk about the details about the architecture of the model we developed. But I want to emphasize it's a transformer-based model, and we make this for the same reason. We make the code and the model public available, so that others can reproduce the results and also use the model on their in-house datasets. And we applied our model on a dataset called deep lesion, which is a large-scale and diverse database of lesions in CT images. It consists of more than 30,000 annotated lesions And by using our tool, we create a set of 171 common attributes based on the red flags ontology to describe those lesions in the datasets. And this dataset is also publicly available in 2019. To summarize in this section, I demonstrate two use cases to use clinical natural language processing techniques and deep learning in assisting medical image analysis. In the first project, we use a rule-based system to extract disease or findings from the radiology reports. And in the second project, I demonstrate how we can use the deep neural network to extract attributes that describe the findings in the radiology reports. So by using the NLP techniques, we can automatically create large-scale fine labels datasets, and using those datasets, we can do some medical image analysis tasks that cannot be done before. So these two examples demonstrates the useful of clinical NLP in assisting medical image analysis. So at the last, I want to thank my colleagues and also the findings that supports those projects. From the talk, probably you have a sense that the clinical NLP is really helpful in assisting medical image analysis. So in my lab, we also have new opening positions for postdoc to continually explore different areas of clinical NLP in assisting medical image analysis. If you are interested, please feel free to shoot me an email and we can go from there. So that's all for my talk. Thank you for your time, and I would like to take some questions.
Okay, I think that's all the tutorial for today. And oh, I got one question. So the question is, are all attributes already labeled? Do you need to train another model to detect those attributes before classification? The answer is yes. The attributes have, to train the model, we need the attributes labeled, and we ask radiologists and domain experts to annotate the attributes for like 800 CT reports in order to train the model. And during the test phase, we don't need the attributes labeled. We use some very simple tool like regular expression or other machine learning based tool to extract the attributes from the CT reports. So I hope that's answered your question. So we actually have 1 minute left for the QA panel. All right, so here's the QA panel. I honestly, I don't know how many speakers will make it, but I'm happy to see that Dr. Banerjee is joining. Hopefully others will join soon. So first, I would like to thank all the speakers for preparing the recorded video. So all the videos are public available. You can find the links to those videos on our website. We make them public available on YouTube, and you can also comment on those videos, and we will try to answer your questions offline. And we will also, if the speakers agree, we will also release the slides after the tutorial. Hopefully, that will facilitate the content, the understanding of the content on this tutorial. So with that, I will just open the questions to the attendances. So if you have any questions, you can either type it in the chat box, or you can unmute yourselves. So I have one more questions related to actually my talk. How is the performance of NACBIO? Do you think it can be tailored to detect negations for other clinical corpus like a clinical trial criteria? So unfortunately, the NACBIO was developed on clinical notes. I feel that there's a big differences between the clinical notes and the clinical trial corpus. So I don't really know the performance of NACBIO on clinical trial, but I think that's a great question. I feel that some rules developed in NACBIO can be transferred to other types of text, but to be honest, I don't. I'm not 100% sure about the performance of NACBIO on clinical trial documents.
Actually, I have like a related question to you about that. Since you mentioned that you're also extracting the attributes, like all the Radilex attributes, that is very interesting. Actually, I don't know, like, how do you see the use of it? Like all these Radilex attributes, like annotating with all these Radilex attribute, how it can help in developing the further image classification model, or how do you see the use of it?
So I feel that by enrich the labels, including the attributes, we can build a detection model that's more accurate than the model that's only using the category labels. But so far, we only use the attributes information in the lesion detection and segmentation on CT reports. I'm sorry, on CT scans. We haven't got a chance to use them in other scenarios. So one example I'm thinking, or we are investigating, is report generation, which I see that you are also interested. And I feel that the attributes detection, if we have attributes besides the labels, probably that will facilitate the report generation framework. I think that's a similar idea to, I got this idea also from the work by Stanford and also NVIDIA.
Right. So actually, actually, I have a similar feeling like you. I think that is like very helpful. Rather than giving the categories directly of the diagnosis, probably NLP should help them extracting the attributes. But the problem that I'm facing actually in my personal work, that these attributes, if it is extracted from the unstructured report, which is not following any standardization, the attributes are kind of like very parsed, because like everyone using their own language space for describing those attributes. If it is only standardized, for example, they're using the bilayer or the layers or any kind of standard coding system, then probably the attributes could be meaningful. But if it is just like any generic city report that doesn't follow any standardization, then I think extracting attribute space is a very difficult problem. What do you think about that?
I think you are probably, I think you are right. Actually, I'm thinking if we have the classes and categories, and if we have attributes, why not using some data-driven methods to build a knowledge? Because directly align the images to the text is, well, there are some works on that, but it's a really challenge. Let's actually go back to the question I want to ask you for your talk. I think we have the same. Yeah. Okay. Before we continue, I like to mention that Dr. Johnson is able to join, but I can only see him in the question and answer panel, not on the panelist. And also Ying Ying is joining, but I can only see her in the attendance panel, not the panel, not on the panelist. But so I'm not sure whether they can talk. But anyway, I just want to let others know that we have two more speakers joining the QA panel. Oh, Subi is also here, but interesting. Okay. So hello, Subi.
Can you hear me?
Are you able to? Okay.
Yep, I'm here.
Great.
Hi, how's it going?
Great. It's really a long tutorial. I'm glad that I'm really appreciate that you can join. I feel less lonely during the tutorial. I think yeah, it's a really challenge to coordinate attendance, especially during the COVID pandemic, because they live in different time zone, and at the same time, we also make the video public available. So I guess some people who are interested in this topic will just watch the videos on YouTube. Okay, so I have some questions. So one question is actually related to Dr. Johnson's talk. So you mentioned that the NLP is only silver standards. I think I absolutely agree with you, and I also feel that well, in other words, it means that even we can develop the NLP tools to 100% accurately extract the labels or other information from the reports, it's not complete. So can you elaborate more about that? And do you have any ideas how we can relieve these issues, whether the structured EHR or other information in the EHR will be helpful in assisting the medical image analysis?
Yeah. I mean, I think there's a lot of uncertainty in medicine, right? Which is partially why it's an interesting kind of area. So, to some extent, it's okay that you'll only ever have a silver standard from NLP, depending on how good of a silver standard it is. I think what you can do is really just expand the scope of where you're looking. So, that's one of the things that I tried to highlight is rather than just, for example, look in the findings area of the radiology report, why don't you also incorporate the indication from the attending physician as a sort of another piece of information to condition on, because obviously the sort of the probability of certain findings occurring in the findings section will be conditional on what the attending is asking you to look for as a radiologist. So I think it's sort of at least historically we've been focused on radiology reports because just in terms of extracting data, it's kind of been an easier problem to scope out. But now that EHRs are becoming easier to work with, people are becoming more familiar, I think we can expand our scope to incorporate information beyond beyond just the finding section of the radiology report into maybe structured EHR data. I mean, obviously the dream is use all the data that you possibly have, but in terms of a sort of feasible way forward, you know, incorporating in other sources of natural language data, I think is a sort of not too crazy step forward in terms of incorporating them into these models.
Yeah, thank you. Another question is that we really appreciate that you spent a lot of efforts to release the data to the public, like the MIMIC 3, MIMIC 4, now we have MIMIC CXR. I think now we have MIMIC ED. So the nature question is that what's a plan for next next step? Do we have any plan to release more data in the future?
I'd love to release like as much as possible. I think it's the way forward, right? Is you know, part of the reason why we only have say only like it's bad, but part of the reason why we have sort of radiology, you know, have their set of models, and you don't really think of the whole medical system, is just because when you're trying to get data, right, radiologists can get this type of data, so that's what you work with, and you know, I'd love to kind of break people out of these kind of data silos that have formed around medical departments. So in the future, you know, we're ground up, and I think the next steps are to bring in some 12 lead EKGs for, you know, that's particularly in the emergency department. If somebody comes in with some sort of cardiac condition, then you would have them do a 12 lead ECG and sort of read that very quickly, but also echocardiograms, and then that's a very interesting modality, because now you're talking about rich video, which brings its own sort of challenges around the size of the data and processing and the challenge of the problem, but also a very interesting problem to have. So I think those are the two main kind of areas that we're going to add to MIMIC and just sort of grow it to be a very rich sort of source of inpatient data.
Thank you. Since you mentioned the cardiovascular disease, actually, that's the next question I want to ask Dr. Araf. So I know that you have lots of work on extracting the information from the CT reports and use those information to predict the patient, the modality of patients with heart failure. And in today's talk, you also mentioned the cardiovascular disease detection on CT. So the question is, how do you see the modal fusion, or how do you see the multimodal data can facilitate the medical image analysis or the disease detection for cardiovascular disease? And how do you think the NLP or image analysis can facilitate and help you to automate this process?
I think it's a good question, and it's a complex question, because as a clinician, I think there's what we try to do is when we look at images, we're trying to first diagnose a disease condition and then use whatever data we can get to give a diagnosis, but also to prognosticate and tell someone you're sick and your chance of having a complication is so forth, and you have a benign condition and there's nothing to worry about. And I think extraction of imaging data to make an automated diagnosis is one of the things that's being worked on, especially with cardiovascular CT, because clinically what we do is we scan patients, and then let's say they come in with chest pain and we're interested in the coronaries, we look at the coronaries, but there's a lot of other data that we ignore in terms of chamber size, chamber dimensions, function, relationship of one structure to another, that we often just glance over and look qualitatively. There isn't a true quantitative way of assessing such measures. And with every pixel, the thought is that there is data that is often ignored or not used. So to develop models that can extract these features, certain segments of the heart, and use them for research or for clinical purposes, that can definitely improve the way we prognosticate or predict outcomes. From a diagnostic perspective, it's just going to automate and maximize the extraction of information from images, because not only can we comment about the coronary arteries, for example, and how much plaque there is, we can also say the function or the structure of the heart is fine, or sometimes if someone has a disease that we miss by qualitatively looking at the images, we can have a mechanism or an algorithm that's running in the background that can make sure that the accuracy of the image interpretation is maximized.
Okay, thank you. Yeah, I think there's a lot of common interests to not only detect the disease from the medical imaging, but also predict the prognosis of certain diseases using the multimodal data. And that's actually one topic mentioned in let's see. In Dr. Banerjee's talk, she's interested in breast cancer recurrence prognosis. So from my understanding in your work, Dr. Banerjee, you only use the features extracted from the CT reports to predict the recurrence of breast cancer. Correct me if I'm wrong. So how do you see, so whether it's possible to combine like the CT reports with the CT scans and other data modality in your framework?
Oh, actually, I think probably I was not really clear. So the model actually used three different kinds of clinic notes: progression reports, oncology notes, pathology reports, and radiology reports, not only like CT reports. So we are actually predicting the recurrence based on these three different modalities. And as you also mentioned before, that is a challenging task, because every different clinic notes is written in a different template, and they use like very different syntax and the language space. So our first task was to standardize the language space so that the radiology, pathology reports and the clinic notes can be brought together in the same language space to predict the recurrence. So that was the main challenging task that we addressed. And another problem was the temporality, because you know that like every patient is coming at different time points, having different types of visit. So that is also very challenging for us. But yeah, so we first tried it on breast cancer recurrence using a weakly supervised NLP model, and it seems that the model can predict recurrence using this temporal model and the defined language space.
Yeah, I'm sorry. Actually, I mean, that's in your model, you only use a textual. I mean, whether it's the CT reports or pathology reports or progress notes, they are all text.
Yeah, all text, exactly.
Yeah, so will you consider other modality like image or lab tests, virtual science, those information in your framework?
Exactly. So that is our actually next step, that we are also using the breast cancer screening mammograms and diagnostic mammograms in our model, and see that it helps to predict recurrence. But as you know that once the breast cancer surgery was done, usually, which is the first step in breast cancer, then the imaging features change a lot, because then we don't have really this kind of like regular breast mammograms, especially for the recurrence, because recurrence mainly depends on the other site and the secondary sites mainly. So that is a very challenging task too. So, but we are currently predicting recurrence even before the surgery. So we are using all the screening and diagnostic mammograms before the surgery for predicting recurrence.
Yeah, thank you.
If I can ask Dr. Banerjee a question just for discussion purposes, I'm curious to see if you've looked, if whether reports, text, does it add more value on top of images? Because theoretically, we as clinicians, we're looking at the images and making the interpretation on a report.
Exactly.
So if you're using the images, does a report add anything on top of images?
Yeah, so that is my main concern actually. So our first model is built mainly with the clinical text, which includes, as I mentioned, like oncology report, radiology report, and pathology reports. So which is already a kind of like interpreted version of the imaging data. So I don't know if adding imaging will add a lot of information for the recurrence prediction model afterwards. So that's why I'm not very much keen in adding images, but just to try a multi-model fusion model, probably that would be another way to go. I completely agree with you.
So the more I'm working on the radiology generalist reports, and the more I feel that it's really a silver standard. But it's quite challenging to get gold standards reports because we don't have. So first, I don't think radiologists are easy to reach agreement, even for themselves. Not just radiologists, but all physicians, clinicians. They intend to disagree with each other, from my understanding. And second, it's a really time-consuming and labor-intense to ask different radiologists to re-study the existing radiology study, like reread the X-ray or CT or MRI. I think that's a quite general questions in the medical domain, especially for the image, medical image analysis. So do you guys have any comments how we can mitigate this problem? What's the ideal approach? What should be done to move this forwards? I think everyone is waiting for everyone else, so I will just Emma, do you have any comments on that?
Yeah, actually, it's you're right. Like even we cannot consider the radiologist extracted information as a ground truth because since it's more or less like incomplete. So that's why I think that whenever we are talking about this kind of image-based label extraction, I think prognosis, like the outcome data, is kind of important to validate the extracted information is right or the quality of the extracted information too. So I think that's why I'm mainly interested more than extracting just the score or the findings from the radiology report. I'm more interested in the outcome actually, that what happened to the patient after like 1 year or 6 months after the radiology exam was performed, so that we can know that the outcome of the patient before even validating our NLP model extracted outcome. So that's why I think I agree with Subi in that case, that probably in that case the image and text will play a nice role together, because then we have the radiology extracted or interpreted data, as well as we have the real scan data from images, and probably adding these two can help the outcome prediction even better.
Yeah, and just to add to that, I think that's the beauty of medicine and taking care of patients, is that things vary, and the way different clinicians and radiologists and pathologists interpret things are differently. If I saw someone with chest pain and I said they're having a heart attack, another cardiologist may come and say, no, I think this is chest pain coming from the stomach and as a heartburn. So that's the beauty of medicine, is that different people interpret things differently. But I think the discussion about text and images is a way standardizing things, because if you see something on an image, it's there on an image. So even if people interpret it differently, you cannot change the pixels. So in a way, I think that will standardize outcomes. And probably with a new generation of physicians and radiologists understanding the importance of machine learning and AI, that will maybe create a coalition or collaboration of individuals who have certain standards. And this way, we can build databases and structures and quality controlled images that can be used for research and to improve what we're trying to do with AI and cardiovascular diseases and other diseases.
Alisa, do you have more comments?
Yeah, I mean, there's a lot to say there, I guess. I agree with him on that. I really like trying to be a bit clever and think of surrogate outcomes. So, looking at, say, something like pulmonary edema, instead of relying on the radiologist to correctly label mild versus moderate, which are very, very ambiguous definitions, to try and pull out some sort of later physiology, which you could use, like if they have pulmonary wedge pressure, then you can sort of use that. So things sort of along those lines are just kind of interesting ways to have more than one, I guess, measurement of the phenomenon, and create a model that's robust to some of the variations in sort of labeling practice. I think that's super interesting, and I think you've definitely seen a lot of work in sort of labeling of images by humans, where they can take a crowd of annotators who can only sort of say 0 or 1, and give quite a variable response to the same sort of picture, and end up with a model which is sort of creating a probability of the event. And I think that's very much possible in this domain. It's hard because obviously there aren't that many radiologists you can get to annotate on a given budget. But I think those ideas are very interesting to like people are saying, consolidate this sort of variable, potentially subjective opinion of many individual experts into a consistent, not always correct, but objective probability of whatever the outcome you want to predict is. I think that's a very interesting thing that will rise up in the next 5 years.
Yeah, thank you. I think we are almost, it's close to 4 p.m. So the last question is actually the future plan, because you know that this is our first tutorial on CVPR, and unfortunately, because of the COVID pandemic, we cannot meet in person. I think that's greatly reduce the impacts of the tutorial, but at the same time, I still hope the audience that the attendees is able to learn something from the basic theory of medical image analysis, clinical text mining, and I hope that they can also have the opportunity to get the cutting edge examples of recent deep learning architectures adapted to the medical domain. So hopefully we can join next year at CVPR 2022. I just searched. It seems that the CVPR next year will be held in Louisiana because we didn't have the physical event this year. So actually, I think the question should be open to the attendance, but so far we only have four attendances in the Zoom call. So I will just open these questions to all other speakers. So for next year, what do you expect in the tutorial, and what would you like to learn, or what would you like to present that you think can attract the interest of the CVPR community?
I mean, I have my bias, but I feel like I always feel like we need to get more people into the medical domain. I feel like obviously, as you would anticipate, the medical domain is dominated by medical scientists, and I'm always, with a lot of my activities, trying to fuse sort of the different domains. And I think coming to a conference like CVPR, we definitely want to just have a tutorial where we say, hey, here's how you get into sort of medical NLP, medical imaging. Here's, like, make it as easy as possible for researchers when they're developing their new approaches to also try it on a medical data set, also have a real sort of medical application. And that's what I would be interested in. sort of teaching, learning, that sort of thing.
Yeah, I think I completely agree with Alistair. Probably even like the next tutorial, probably we can do some hands-on thing, because since this tutorial will be online anyways in YouTube, probably we can like share some data set and we can do the demo of the different methods that we are proposing and how this method can extract information and how this information could be used in developing actual image analysis or deep learning models. I think that would be probably nice for the whole community, especially the computer vision community.
Yes, I totally agree. And since our speaker group is quite diverse, maybe we can come up with some multi-site data sets so that
Right,
the
exactly.
attendees can play with during the session. Hopefully there won't be any IRB issue, but definitely that will greatly facilitate the studies on medical image analysis.
Right.
All right, it's already 4. Thank you again for all this for everyone to join this tutorial, and thank you for all speakers to take the time to prepare the recorded video and join this PA panel. So last but not least, I hope we can see you at CVPR 2022 in Louisiana. And again, if you have any questions, you can always ask offline. You can we make the video available on YouTube, and we will release the slides if all the speakers approve. So that will be all. So see you next year.
Thank you for organizing this. Thank you. Bye.
Thank you.
Bye bye.
Bye.